Morning. Can I welcome everyone to this, the 33rd meeting of 2012. Can I ask everyone to switch off mobile phones and other electronic devices completely as they interfere with broadcasting system, even when which to sun. And I have apologies from David McCletchie. Item 1 on the agenda, transfer of prison healthcare to the NHS. This is a roundtable discussion of the transfer of prison healthcare to the NHS. And members will recall that this issue was identified by the committee as one to explore further. As you can see, our 9 witnesses are interspersed, which is a wonderful word. You've been interspersed witnesses amongst members around the table to encourage more open and informal debate on this issue. In fact, we want to hear more from you than we do from committee members. Witnesses, you're welcome to address each other directly if someone wants to make a point that you want to add or indeed to challenge. Initially, if you do it through me, but usually we find it gets its own kind of rhythm going and we just leave you to it as long as there's not a punch-up. Now, I'm going to let everyone do a brief introduction round the table, just who you are and who you represent, and I start to my right-hand side. Jenny.
My name's Jenny Mara. I'm Deputy Convener of the Justice Committee and Labour MSP for North East Scotland.
I'm Richard Groden.
Well, can I just say your microphones will come on automatically because we've got a whiz kid here working at the switch here. Whiz kid. Right. On you go.
Richard Groden. I'm Clinical Director for Glasgow City CHP with responsibility for prison healthcare.
I'm Roderick Campbell. I'm a member of the Justice Committee and MSP for North East Fife.
I'm Frank Gibbons. I'm Healthcare Manager at HMP Barlinnie Prison.
I'm Colin Keir. I'm the member for Edinburgh Western and member of the committee.
I'm Mark McEwen. I'm the Planning Lead for Prison Health and Police Health in NHS Grampian.
John Finney, MSP, Highlands and Islands, Committee Member.
I'm Gregor Smith. I'm Divisional Medical Director for Primary Care in NHS Lanarkshire and Senior Medical Advisor to Primary Care Directorate in Scottish Government.
I'm Peter Wilson. I'm the Health Strategy Manager at the Scottish Prison Service Headquarters.
I'm Ruth Parker. I'm currently Acting Assistant Director for Health and Care, Scottish Prison Service.
Sandra White, MSP, Glasgow Kelvin.
Leslie Graham. I'm Associate Specialist in Public Health at Information Services Division.
Alison McInnes, MSP for North East Scotland.
Marion Logan, Director of Operations for Scotland for Phoenix Futures.
Graham Pearson, MSP for South of Scotland.
Kirsty Pate with NHS Lothian. I manage Willow Services.
I'm Christine Graham, Convener, and I represent Midlothian South, Tweeddale and Lauderdale. A very short title. I wanted to start, if I may, before I open the discussion, with a quote from Dr. Leslie Graham's report, a healthcare needs assessment, which she says, this is of prisoners, they are risk takers in every sense with a liability to addiction, sexual disease, physical or emotional trauma, many with significant brain damage, and at a much higher risk of early death. The majority smoke, have drug problems and mental illness. A significant minority report alcohol problems and experience of abuse. Their lives are chaotic. Their health and physical, mental and social dimensions is poor. Experience of prison can erode, preserve or strengthen the first two, but reliably destroys social well-being. Well, that's some issue to tackle. I thought I'd put that on the record because I think that encapsulates the issues that you all face. And now I'd like you to just discuss, as it were, the benefits and disbenefits of the transfer of healthcare from the SPS to the NHS. Volunteers. It's like being at school. I'm going to pick somebody in a yellow jumper or something. Graham, if you would just ask a question first.
I can maybe ask a question. Obviously, the transfer of healthcare has moved from SPS to NHS. Would any of the participants like to outline for us the practical changes that have been delivered and what challenges have been identified at the outset?
Can I just thank you before I proceed? Can I thank you all for your written submissions? I should have said that. It was very, very helpful. Right, here we are. Practical changes. There have been none, apparently. Yes, of course, certainly. Marion Logan.
Phoenix Futures have had a contract in Scottish prisons since 2005 to provide enhanced addiction casework services to working with a lot of the individuals that have got identified that have got alcohol, drug and indeed smoking issues. On a practical level, our contract transferred from SPS to NHS when the healthcare transferred on the 1st of November last year, and that has resulted in ongoing uncertainty as to what happens to the future of those services. So there's ongoing uncertainty for both our staff and indeed for the thousands of individuals that we work with.
Dr Smith.
In NHS Lanarkshire, we took on the responsibility for Her Majesty's Prison Shots, and we found ourselves in a position which was to look after a prison population which was fairly stable in its nature. So that allowed us to plan services more effectively than I think look at the kind of longer term care for these prisoners. I think one of the things I would first want to highlight is that the process of transfer was a very good process, and that working with Scottish Prison Service and the various partners that were involved in it, everything worked very smoothly. There was a real spirit of partnership as we tried to develop the services. And what we've striven to try to do in terms of what have we done for prisoners receiving healthcare, we've striven to try to ensure that being in a prison is no barrier to healthcare, and that there's an equivalence of what prisoners would get inside Shots compared to if they were in our population as a whole. I can give some practical examples of that if members. Well, I think one of the things we've tried to do, if you take dental care as an example, it was fair to say that dental care is of great importance to the prison population for a number of reasons, and I think what we have done in particular is bring the standard of care much closer, and particularly access to care, much closer to that our general population would enjoy. And as a result of that, I think the number of complaints that we've had round about dental care, for instance, has greatly and substantially reduced over that time. We could also make some comment about trying to get the kind of care round about addictions much closer to the integrated community model that we have in Lanarkshire as well. So it's small steps, but progress.
Mr McEwen.
Yeah, I would just like to add to that exactly the same point. I think I made it in my... Sorry. Exactly the same point in Grampian in terms of dental care. And one of the things I think that's been a great benefit, not only have we increased the number of times that prisoners are seen by dentists, but they're seen by community dentists from NHS Grampian. And these dentists have a particular interest in homeless and substance misuse population out with the prison. And in terms of through care, what you're seeing is a familiarity, if you like, with the same practitioners, so they're getting very similar care within the prison as they're getting out with. And that's a kind of general point that I think is a key benefit of the transfer to NHS. I know for female prisoners there was sometimes a reluctance to access, this is anecdotally, but I think it probably holds water, to access services when they were out in the community. And I've heard of some of them trying to get back into prison to access very basic services. But I think if you're being attended to or provided your service by somebody who's branded NHS, it just breaks down a barrier from when you go out into the community. You feel that that's who provides your health service. So from that point of view, I think it's been very good.
Are you wiggling your finger to come in, or just
I would like to come in,
Mr. Grodin, if you just make it plain to us. I know it's not just a nodding of agreement. Please do, yes.
Yes. It was just to reflect on what's happened within Glasgow and Clyde since the transfer took place, and I think there's been a number of developments that are ongoing, but one of the first big pieces of work we undertook with was a health needs assessment undertaken by public health specialists to identify the needs of the population, and that was a particularly good piece of work which has led us to move forward in identifying posts for learning disability support within the prisons, and these are currently being advertised. These are work not only with the individuals themselves with learning disabilities and identifying them, but also raising awareness within the prison workforce, including working with SPS, training them to identify where people have learning disabilities and how they can access support, and linking into community services on release. Other areas are around addictions as well. Two of our GPs that we've been able to employ, and I think one of the advantages has been in the medical staffing, we've been able to select the doctors through an interview process and match some of the needs with some of the skills of the doctors. So two of ours are very experienced community addictions doctors as well, who are currently working within Burlunian and Low Moss. And I think that's an added advantage to support the addiction services that are currently in there. So I think there's been a number of pieces of work. These are just a couple of examples that I'd like to share with you today.
What happened before? If you interviewed them this time, did they not? What happened before?
Well, we interviewed them on the transfer because there was we had one doctor who transferred over under TUPE arrangements from Medac. So previously there was an agency who provided medical cover to the prisons, and it was they had the contract to do that. I wasn't involved previously, so I wouldn't like to comment on either who was in the service or how stable the doctor population was working within the service. But there was a recruitment to try and get doctors to work in the service when we took it over.
Could somebody maybe elaborate on that? Because, yes.
Previously, SPS had a number of contracts for services, medical services, doctors, if you like, being one of them, and that was just a national contract. That would have been similar for things like dentistry. The pharmacy one is actually still continuing, so it wasn't the responsibility of local boards at that point. It was completely separate.
Thank you. Do you want to come in now, Mr Gibbons, or be...
Yeah. But just basically to say, I've went through the transition as a healthcare manager with SPS and transferred into NHS, and I see sort of significant improvements for prisoners in terms of the links now that we can make with NHS, and particularly the new IT systems that we use mean that we can get information on prisoners coming in very quickly, which allows us to continue care and link in with people who are providing care in the community. And similarly, we have systems that can provide us with results, blood results and various other hospital results that mean that we can treat prisoners far more quickly than we could previously. Education for staff providing nurse-led clinics and for GPs as well is on par with NHS, which was hard to for us to gain under SPS. So we've got the expertise there now, and the services, as Rich has pointed out, when we carried out the health needs assessment, we looked at what services were delivering to a very good standard, and there were many that were of a good standard, and we're trying to improve in areas where we were a bit weaker. And some of these new IT systems, the education, the induction process that the staff have went through have empowered us to improve with the overall care.
So the induction's like what you were doing, interviewing, and so Peter Wilson, you wanted to come in as well.
Yeah, it's just a point of clarity in relation to what happened prior to the transfer in terms of recruiting medical officers. The Scottish Prison Service had a national contract for the provision of medical services in the publicly run prisons in Scotland, and that contract actually came to an end at the point of transfer, and it was for the health boards to then recruit doctors to provide services in the establishments, and it was individual health boards who then recruited the doctors for the establishments within their patch. In terms of pharmaceutical services, there was also a national contract for the provision of pharmaceutical services, and that was a contract that actually transferred to the NHS. So there was a number of different ways in terms of provision of services, and the staff, the nursing staff transferred under COSOP arrangements. Doctors finished providing services because of the contract. The national contract for pharmaceutical services transferred to the health boards, as did the Phoenix Futures contract. So it's just gives some clarity in relation to...
And the legal thing, I'm just wondering, does it mean that somebody who is in prison being treated by a GP will probably or may have that GP once they leave prison? Is there continuity? I think that's...
In terms of providing services, no.
Right. Yes, Graham, I've got other folk. I'm going to let Alison in. Okay, then I'll take Alison.
It's not the reason I wanted. Pharmaceutical services. What do you mean by that? Just so we're not off at a tangent or different thinking. What does pharmaceutical services include?
It was the provision of professional services and also the provision of medicines.
Thank you.
I'll take Alison, and then do you want to come in there or first? We're going to take Alison McInnes.
I was just going to elaborate on the GP provision and who these people are likely to be. We have a range of people working in Glasgow and Clyde, working from 2 sessions a week up to full time. The people we also have a bank of locums who are working in the community as well, who are able to come in and supplement the numbers that we have in the prison or fill in any gaps that we have in the rota. All these doctors will be working as general practitioners, bar the 2 who work in addictions, but they have extensive general practice experience as well. But they won't necessarily be the individual's GP when they move back into the community.
Thank you. I've got Alison. Sorry, I've been very patient.
Thanks, Convener. I mean, there's a lot of evidence that there was clearly a lot of unmet need, and that the way that the prison service was providing healthcare was through triage and crisis intervention rather than the more holistic approach that you're all talking about. So I'm really heartened to hear what you're saying at the outset. I wanted to go back to the dental provision, if that's possible, and perhaps hear from Mr Groden about Berlini and things, because I spoke with a prison visitor from Berlini earlier this year, and she had been discussing the provision of dentists there, and she said that one of the prisoners had asked her to take up the case. We went to the health centre to check on what we'd been told. Although 2 dentists hold clinics in Berlin daily, there's a huge demand, and only those graded emergency would be seen immediately. Urgent takes longer. And when we asked what constituted an emergency, we were told, and she said this was a direct quote, if your face is so swollen that you're having trouble breathing, or they think septicemia is setting in. I'm kind of hoping that things have improved significantly since then. And I would like to hear reassurance that there's a proper dental provision available.
I think I'll ask Mr Gibbons first, because you're HMP Berlin.
There is dental services is one area that's been looked at very closely, and the NHS have recently decided to invest additional money into providing additional sessions in the afternoons. So we're looking for over a 6-month period to have some additional sessions provided to try and bring the waiting list down. One of the issues, though, that we have to be clear on with dental services that causes a problem is that every prisoner lists themselves as an emergency and says that he has toothache, because that is seen as a way of being seen quicker. And it's largely, it causes a lot of problems with guys who are genuinely, or prisoners who are genuinely need to see that dentist. So we're trying to sort of do some educational prisoner focus sessions to try and get away from that culture, but it's a well-established culture, and it'll take some time for people to change how they actually access that service.
Do you wish to comment, Mr.
I just wish to comment on dental emergency as a category, because in the community, my understanding is dental emergency constitutes severe pain or dental hemorrhage, and these are the only 2 rationale for a dentist to see any patient as an emergency. An emergency is constituted within 24 hours. Not as a medical emergency where it would be immediate care. So I think it's important to see it in the, on the basis of that when you're talking about dental care within the prison environment.
Dr Smith. Oh, sorry. I was going to get Dr Smith in there and then come back in.
It's worth reflecting that point that Dr Groden's made there, because it's a very important point that what we're talking about is equivalence of care. And although we continually want to strive to improve our care in any dimension or any that we deliver it, what we shouldn't do is set up an inequality in care or in provision of care that's unrealistic.
Absolutely, but I think we would have a long way to go before we got to that point. If there's an emergency category, what's the urgent category, and what are the kind of timescales for that, and would you expect to meet those within the prison as well as out with the prison?
Maybe ask Frank to comment on that.
Yeah, emergency care, we are trying to get somebody seen within 24 hours. We also have provision during holiday periods to take people out to the dental hospital should that be required. But when normal Monday to Friday services are on, people would be seen fairly quickly, and we would certainly have people seen by a GP and given some kind of pain relief or analgesia whilst they were waiting, if it's say from a Saturday morning to a Monday morning, so they would be seen by a GP. Okay.
I'd like to, I think, but certainly not saying dentistry isn't important, of course it is. I'd like to move on to addictions, which are, the major issue for us, and obviously looking at people churning through the system. And separately perhaps to look also at mental health problems, which is a huge issue as well, psychological, psychiatric issues. So if we could talk about how these have changed, how handling these has in any way changed since the transfer of the contract. Now, you're out of sync with everybody here, and I'd like to hear that. It's not a bad thing to be out of sync with everybody, because you don't think it's all the garden's rosy and it's all been good. Now, this isn't special pleading, is it, on behalf of Phoenix Futures, is it?
No, it's reflecting the the issue that we've got within the prisons. I mean, it's a massive service and there's a huge demand, and it's just that ongoing uncertainty that causes issues.
You're making a point in your paper that the voluntary sector has kind of been ignored in all this and pushed to the side, or if I'm paraphrasing it, but would you like to please just develop with the others, particularly with relation to the addictions and through care, the interlinking between what's happening in the prison and obviously what happens outside from your point of view, so that you can challenge some of these people. I like a little bit of a fight. But you know what I'm saying? It's not, I want to hear some of the difficulties, not just obviously the benefits, but there must be things that aren't quite working.
I mean, ultimately, the point of, or one of the expectations of the transfer was that it would improve, particularly through care, and it would improve that link between the healthcare aspects of it, dealing with addictions, and the more holistic aspects of dealing with somebody's ongoing recovery. And one of the unintended consequences, I believe, of the transfer is that hasn't happened. I mean, the partnership that Phoenix Futures has had within the prisons, both with SPS staff and with NHS staff, and indeed the other organisations that work within the prisons, is really important. And the point I was making in the submission is that it would not reflect the community, and it would not be in the best interests of those individual prisoners with drug, alcohol, smoking issues, is if their issues were seen as being wholly under the remit of healthcare services, because that's not how it is in communities. And also the need for the voluntary sector to be part of individuals' recovery journey has been, widely recognised, not least in the recent drug strategy debate a couple of weeks ago, and reinforcing that, the road to recovery strategy. So that it's been an unintended, I would like to think it's an unintended consequence, that the ongoing uncertainty as to the continuation of this enhanced addiction casework service, so that we don't end up with just a medical model for addiction work within the prisons.
Do you want to say anything, or do you disagree? Or
I suppose my comments are quite specific to the service that I manage, and to that extent I don't have the kind of breadth of knowledge that's been debated here. To pick up on a couple of points that I think relates to that is the service that I manage provides integrated services, and I think this is one of the issues that's maybe been highlighted here, and it is a real challenge for all of us within NHS, the council and the voluntary sector. We do like to think that we're good at working together, but it's very, very difficult. I think what can often happen is we end up delivering services parallel to each other rather than in an integrated basis. And I think that's one of the issues that's been highlighted here, that really partnership working is very, very complex and very difficult. Your initial kind of comment, I think it was Mr Pearson, around the practical changes, but some of the challenges, and I think one of the challenges that continues and will continue is around partnership working and that being equal, because essentially I think that the bigger players in this are used to being the bigger players in this, and we're having to shift some of that. And I think there are really good examples of where that's worked well. I would like to think that Willow's one example of that, but there are others. Well, Willow can speak about particularly because... You
said there's other examples. Which are the other examples?
The 218 service in Glasgow. I don't want to talk about masses of services I don't know enough detail about, but certainly Willow and 218 are ones that I'm aware of where there is very close and integrated services. We sometimes see it working really well in drug treatment testing order services as well. But I think there's a massive challenge around partnership working. Excuse me, it's not an easy thing for any of us, but I do think that there's been a lot of efforts to move things forward, and we've been hearing today about some of the really positive examples of how that has worked well. The other comment, if I can just take the opportunity to make it, I think was around the provision of equivalent care. And again, I suppose just from my perspective, I think one of the continuing challenges that we will have is that the discussion around equivalent care, and that actually providing equivalent care to a very broad and complex population doesn't always equate to equal outcomes, and therefore equivalence in care may not ensure equal outcomes for specific people within the population. And I do think that people are taking account of that, but it continues to be a challenge for us. So, for example, I think in Leslie Graham's submission she talked about outcome measures and indicators. What is success? I mean, some of what we're talking about today is fairly anecdotal because we don't have national indicators about success in this area. And I would recognise that one of the challenges in that is ensuring that our outcome measures are gender specific and that we ask the right questions to make sure we get the correct answers in relation to what is progress, what is success going to look like. And that might mean asking different questions for women that we do for men, particularly around mental health and addictions.
Can I also ask why, I'm just going to take you in, Dr. Again, we tell everybody with that, but can I ask why it doesn't say returning to prison as one of the things you can measure?
Sorry,
but you're asked about measuring outcomes. So one simple one is to say, do they go back? Do they, once discharged, despite all your endeavours, they go back to prison? That's something that's easily measured. But I'm bringing you in, Dr. Graham, right now, and I'm going to tell everybody where they are now. Because I've got Dr. Graham, I've got Ruth Parker, I've got Mark McEwen, and then I've got Sandra and John coming in as members. Right? So I'll take the witnesses first. Dr. Graham.
Okay, thank you. I was going to return to your initial comment about addictions and just draw committees and others' attention to a series of research projects that I commissioned along with Health Scotland, looking particularly at alcohol problems. It's noted in the briefing paper, and it's a prison health needs assessment specifically looking at alcohol problems. And that was work led by Stirling University. And that evidenced that there is a high prevalence of alcohol problems. We also looked at the literature around what are the effective interventions, recognising there's a whole range of interventions, whomsoever they're delivered by. We interviewed both staff and prisoners themselves, and there was this recognition, it was a sort of recognition from both sets that there was, alcohol had been in the shadow of drugs, and also there was perceived sort of lack of full integration of the service as was delivered then, that there was, if you like, a sort of medical stream, and then there was the addiction casework service stream. That's not to say that it shouldn't have been, but there was a bit of a disconnect. And I see what is an opportunity here is that for addiction services going forward, that they can become fully integrated, that there is that leadership there that can bring that about. And absolutely echoing Kirsty's point about partnership working. Through care also is an area that's needing attention and more effort. Just to highlight that Health Scotland and myself and others have been working since then with alcohol and drug partnerships and community justice authorities to try and get those strategic partnerships working. And indeed, on the back of that work, there was £750,000 sent out to ADPs to enhance alcohol and prison work. So that's really, that there has been quite a lot of progress, I feel, in terms of mapping out what the problems are and even setting out an effective model of care. That's on the alcohol side. To pick up, and I can come back to it later, but the main thrust of my briefing paper is exactly what's being said. How do we measure success? And I can either speak to that now or if you want to come back.
Oh, just go for it.
Okay. Well, I think one of the big questions is the health of prisoners better, worse or the same? And it was difficult enough when I was doing my prison health needs assessment in 2007, which I've outlined in the briefing paper in terms of the sort of lack of a fully electronic healthcare system across all the care that's being delivered. There have been steps forward, and happy to hear from Mr. Gibbons that there are progress being made. There is now a bespoke IT system called Vision, hosted by NHS Grampian. Although there are still gaps, I think, I perceive there are gaps, particularly around mental health and some of the addictions in terms of what data can be collected in. What we haven't got now is any reporting other than heat standards and so on for what is going on in prisons. There's not a routine reporting system. The network, Prison Healthcare Network that's been set up, has just established a work stream. We've already identified a good few, something like 60 or so indicators that we can narrow down that we could measure. So there is, again, progress being made there, but I still feel we can't yet fully answer the questions. Has the health of prisoners stayed the same, got better or worse?
With a view to them not reoffending. I mean, of itself it's a good thing, but absolutely. I think as the Justice Committee we're also looking at...
Absolutely. I think...
at the end of the day...
That's been one of the principles, is about by addressing health and healthcare
Indeed.
needs and wider needs, that you will have the double win of reducing, triple win of reducing reoffending, reducing health inequalities, and also improving, hopefully, the health and well-being of prisoners and their families.
We've returned to Ms Parker. You want to come in now?
I did. I wanted to come in and discuss the Enhanced Addiction Casework Services contract and just clarify that the Enhanced Addiction Casework Services was not provided in all prisons by Phoenix Futures. There were 3 prisons initially, Low Moss, and the 2 private prisons, Kilmarnock and Adwell, who had other arrangements. But it's about the service delivery rather than the provider. It is in the Memorandum of Understanding that health boards will continue to provide that service, and how that happens is entirely up to health boards in the future. I know that work's happening at the moment because I've been actively involved and invited to participate in work in Forth Valley, and would like to share that model with the committee. And that's about integrating the health services, the Enhanced Addiction Casework Services, the wider through care services, and having that pathway of care from admission across to liberation, and also taking into account research that's been discussed by Dr Leslie Graham, in particular the alcohol research, the funding that's been allocated to alcohol and drug partnerships to support that, and that work is currently being shared across alcohol and drug partnerships by Forth Valley, and will also be shared with the network at the January meeting as a best practice model. I have to say it is just in draft form at this stage, but it looks like something that could be adopted by health boards in their geographical areas.
You didn't say thereafter. You went from admission to them
across their sentence,
and then when they're in fact finished. But you didn't then. My understanding, reading the papers, is it takes months and months, if not years, of support to stop people just regressing. So what happens thereafter?
Absolutely, and as part of that pathway, it's about that multi-agency working and the wider holistic approach, not only from the health and addiction services, but the wider, in prison we call it integrated case management, and that's taking consideration of the individual, their person-centred needs, their family, the wider training, employability, learning, and wider into the through care services in the community.
I'll let Sandra and John, and before I let any more witnesses in, I've got a list of you, but Sandra, you might want to come in then, John, and then I'll go back to witnesses, then take Graham.
Okay. Thank you very much, Convener, and good morning to everyone. I've been reading the submissions, and obviously they're very interesting, and there obviously is certainly improvement with through care, but obviously there's a little bit of concern regarding Phoenix and perhaps the voluntary sector, and obviously the professional NHS sector. But I was very interested in Dr Graham's paper regarding, the mental health, the suicides. It's quite horrific reading. You read about people dying from 3.5 times higher in the general population, men who have been in prison. But what I wanted to ask was about the research and through care terms as well. And obviously you mentioned yourself, Ms Parker, yes. You're looking at a draft agenda report. How difficult is it? I mean, I've visited Burley previous occasions when I was on the Equal Opportunities Committee to speak to prisoners, and also Corton Vale as well. And we're talking about the reoffending in the justice system. How difficult is it to, probably the wrong word to talk about, keep track? But when someone, is released from prison, they've been, obviously getting attention in prison, medical care, and it is improving, and obviously had to improve. And then perhaps they move and they reoffend again. How difficult is it to basically keep track of the varying prisoners' needs so that we can produce a proper paper, saying that this person, perhaps they had problems, addiction problems normally, in prison. They certainly weren't cured, but they were getting attention for it. Then they're released, then they reoffend. Is their addiction worse or is it less? I mean, how difficult is it to produce a proper research paper to let us know exactly, because obviously it's Justice Committee reoffending, but it's also more holistically the health of the population.
Who wants to come in there? Mr Gibbons?
Just before I answer that question, I think it would be good for the committee also to recognise that this transition is in its very early stages. Because it's been a significant change, and for staff particularly, it's been a very arduous change in terms of the amount of change coming in. So if I can go back to Marion's point, I don't see addictions being based on a medical model in the future. I think it would be very much multidisciplinary and an engaging way. A third sector, I think people would welcome that, but I don't know that we've got a model identified that is absolutely perfect for all things at this minute. We're still working through some of these issues. But to answer your question about how difficult it is difficult to track prisoners. If I speak about Berlin, I can only speak about there from a local prison and how busy it is. We can get prisoners from all over Glasgow who come in literally off the streets and trying to trace where they have been, because when prisoners come in, they aren't always able to tell you what they've been. Some of them are intoxicated, some of them are a fairly bad way. We've still got a piece of work to do with the Scottish Prison Service in relation to the transfer of prisoners, because we still have prisoners transferred from Lanarkshire Health Board to Glasgow and from Ayrshire Health Board to Glasgow from the private prisons. When our numbers decrease, we take increased numbers, and it's the same with Grampian region. I'll transfer folk if there's works or various estate issues within SPS. Then we receive prisoners from all over Scotland, and trying to tune in to every prisoner's health board and their addictions provider is a very difficult task for our staff, and there's maybe an opportunity in the future to look at healthcare in a more or a more significant way in relation to transfer of prisoners, because just now I think mainly the transfers are based on their security issues as opposed to their healthcare needs issues, and that would certainly be helpful in the future, if that makes sense.
Somebody else want to comment on our... Right, I've got John, you've been waiting a while, then I've got Graham and Jenny, but I'll take some other witnesses after, so have you now, just on John,
Thank
please.
you, Convener. I'm going to be unashamedly parochial. Inverness is mentioned in Ms Logan's submission, and I'm grateful to Ms Parker for her comments. I did read the Phoenix submission as I have to say, a promotion, could cynically say a bit of an advert, but there was a couple of phrases that I highlighted in it, and one of which you've used this morning that concerned me a bit. And if I may just put these on the record again, to assume that the prison addiction services are best run by the NHS without voluntary sector involvement negates the added value of having non-statutory involvement. And then perhaps a bit more concerningly over the page, however, to assume this can be achieved without drawing on our wealth of experience and to support our continued involvement of working with individuals on the road to recovery is to misunderstand both the recovery journey and the role of the different types of organisations have to play at different points on that recovery journey. People out with the Parliament, you'd be surprised at the detail they pay to specific issues. So I'm concerned that I have to address the suggestion that's implied in this, that with the removal of Phoenix from providing provision in Inverness, that there's some diminution of service, when the reality, as I know, is that NHS harm reduction in Phoenix, for instance, and others are actively involved. I just wonder if you'd care to comment on that.
The point that I'm making is not that the NHS couldn't provide the same services and do the group work and the one-to-ones, but the purpose of the service was to offer something different from what the NHS is providing in terms of what their addiction nurses were providing, and particularly the role that methadone plays in the prisons. The point of my paper was to illustrate that one of the, as I've said before, unintended consequences of the transfer is the continued uncertainty, and I get the point that it's still in its early days and it's massive. But the issue,
I maybe should have said that. Where is the uncertainty? Sorry.
Because we don't actually know, our staff don't know, and therefore the thousands of people that we work with, we don't know how much longer we're providing this service for, because there's uncertainty over the contract, and we've been living with this uncertainty since last year. But isn't that
the case with most contracts with most voluntary sectors where there's a service level agreement?
I think most contracts, you have a start date and you have an end date. We had our end date, and now there's a question mark being raised as to whether or not what we thought was our understanding of the contract is the understanding of the contract. But my point is that the role that the staff play and the experience they've gained is a much valued service within within the prison estate. I'm not making the point that other providers couldn't provide the same service, but the point is that within the addiction services, there are different roles for different organisations. And I think the government has, on numerous occasions, recognised that the voluntary sector has an important role to play in this as the statutory sector.
I want to draw out from Inverness and the particular services that you provide, and you're quite right, you've done it yourself, as to the role of the voluntary sector. And I think, Mark McCune, you were going to say something there about that particular, were you, or something else?
Yeah.
Yes, please, yes.
Specifically in relation to the expertise, I suppose, that is perceived to be at risk. I know, although I work in Grampian, I've been working with a number of health boards around about this issue. Essentially what Ruth outlined in terms of the kind of Lanarkshire model of looking at the whole pathway, if you like. And I know in Highland, in fact, they've tupied in the staff from Phoenix, so they have retained that expertise, if you like, and developed it. I guess one of the key issues for me around about this whole area is that, for me, the prisoner journey starts in the community, and for most, it ends in the community. They're arrested, in between then they go through the court system, they go through the prison system, but they return to the community. And that's why it has to be integrated. And for me, in terms of the voluntary sector thing, the thing that I guess sits uneasy with me in terms of a national contract for that is, I would like to think that prisoners within the prison setting, upon release, will get something very similar in the community. And it's difficult if the national provider doesn't have a local community base to provide that. So that would be one of my comments on one of my ongoing concerns, if you like.
We're not just talking here about Phoenix, we're talking about, no, we're not. We're talking, I understand your point, we're talking about voluntary sector. Yeah. Yes, you could have localised ones that would be useful. I take your point. I think you've made an interesting point about the voluntary sector and the fact this has only been running for about a year. I want to ask the witnesses, I've got Richard Gordon and I've got Dr. Smith. Do you want to come in now, or do you want the rest of the... I've got Graham, Jenny and Rod who want to ask questions. Do you want to hear the questions first and then come in? Yes. So I'll just take some questions from you. I think I'm trying to manage this. Graham, what's yours about?
Thank you, Convener. I suppose there's two parts, as usual, to what I've got to say. One, in relation to the submission from Dr. Leslie Graham. On the second page, in the middle section, she indicated her involvement in the National Programme Board for Prisoner Healthcare and talked about the reaching agreement for performance management for prison healthcare would be with the NHS, but did not reach objectives on agreeing a set of monitoring indicators. But then went on to say, it was a high priority. So from December 2011 to the present day, it would appear that this is a high priority, but we seem to be waddling along without getting on too far. And given the statistics that are quoted in page 1, which was referred to earlier by one of my colleagues about suicide, etc., that seems to me to be ridiculous. But my main point is that, having listened to our discussions so far, and we've talked about the movement of healthcare, and I do believe that the changes that you're trying to bring in are very useful ones, and I welcome it. But multi-agency integrated service, person-centred needs, partnerships, multidisciplinary, holistic approach, models, route maps, pathways and the journey. What I don't have an impression of just now is that as a group we have a national strategy for dealing with the addiction needs of these prisoners, which seem to be one of the major reasons that they're currently in custody. And I just don't get the impression as yet that although you're all having a bite at certain wee bits, it's great that they're going to have great dental care and so forth. What are we doing about this major problem of nearly 25% of the prison population with problems in terms of addiction? We already know the alcohol problems involved there. Where is this move forward with the new NHS approach to healthcare within prisons, which will complement the other? I don't see this as just your problem, but where is the bit that you're going to do that will effectively move us forward? And I would also challenge, there was a bit in the submission from the Phoenix Centre that talked about effective illustrations and served Scotland well over the past few years. we've gone from a position of 55,000 problematic drug abusers in Scotland a decade ago. We're now up to 59. The numbers of methadone users within the country is on the rise. The cost that's attributed to it is moving exponentially. So, sorry for depressing everybody around the table. Please cheer me up and tell me that we just haven't mentioned what this collated approach will be. Fill me with confidence.
Well, I mean, I agree with you. I think the committee all agrees with you. This is the real cause. And this is the thing we should be measuring at the end of it. And measurement will also be if you're back in prison because of your addictions. That's when we really find out what's going on. And we haven't really got to that. So I've got Marion Logan. I'm followed by... Now, I've had other people on my list, so let me know if you want to come in on this particular aspect about it. So who else have I got? Dr. Graham and Dr. Smith. That's for a starter, and Richard Grodin. In that order, right? If you can write that down for me or I'll get lost. Right, starting off with you, please, Ms Logan.
I just wanted to make the point that we weren't starting from the beginning with this transfer. We already had lots of partnership linkages with a lot of other organisations. And through care arrangements, whilst not perfect in any part of the country, we're certainly there in order to link up an individual with services in the community. Some of those through care arrangements ensuring that an individual's support and care continues on release work very well, and some of them needed to be improved. But one of the consequences of the transfer is that as more individuals, and particularly individuals who hadn't prior had any experience of working within a prison, they're having to skill themselves up in what that involves. But the models were there and through care arrangements were there, so we weren't starting from the beginning. It's disappointing that some of these models that are being talked about aren't actually going to have anything new within them. I also want to bring up the point about the record keeping and being able to evidence the achievements that are made within the prison, certainly within the addiction services. They do comply with the heat targets that are set for waiting times, and certainly the Phoenix staff submit to those heat targets. So you get those statistics on how quickly people get seen. So there are records there, and the same with the SMR 25 database, which is the database that's used within the community as well, and those forms are completed. So there is information there in order to be able to look at the whole volume of work, and in fact there are a number of organisations that also record outcomes information. So that is there, it's just whether or not collectively we're interested in looking at it.
What about your success in finally someone not reoffending?
Yeah.
I mean, get to that. What records are there about that?
I think the issue is that it would be possible to do that if there was the will collectively for those organisations to report into that. So, I mean, like within the various tools that are used amongst both statutory and non-statutory services, that information is collated. It's just nobody brings it all together to look at it and say, OK, what does this say? It tends to be reported on an individual organisational basis rather than on a collective basis, but it's certainly every organisation would be able to submit.
Well, I find that quite breathtaking, but I mean that's when we come to the crunch. And all this public money is being spent, and a lot of people are putting a lot of effort in the voluntary and the statutory sector, and we're sitting here, nobody can tell us, even for a period of time, how effective all this is in terms of the revolving door for prison. Dr. Graham, perhaps you'll help us. You're down on my list as well.
I was going to answer that very point.
Well, I'll let you answering a different points.
I was going back to the lack of progress and
let me just get the measuring the reoffending, please. Yes.
I've got some information here regarding opiate substitution therapy and the effectiveness of that. Particularly within Greater Glasgow and Clyde, in some of the outcome measures are drug-related deaths. Those with methadone in their system related to death. The cost to health and crime for those not in treatment versus those in treatment for less than 1 year and those in treatment for more than 1 year. And what we see actually in the reduction, and that was information that was produced by the Scottish Government commissioned report in 2009, assessing the scale and impact of illicit drug markets in Scotland. And the outcomes are, for those that are not in treatment, those with addiction problems not in treatment, drug addiction problems not in treatment, the health cost annually is £3,005. those down to 1536 for those in treatment for less than 1 year, and 1173 more than 1 year. When you look at the crime cost, that goes from £12,713 to £1,536. Now, these are figures that were produced by the Scottish Government in 2009, which evidence the benefit of substitute prescribing for this particular population.
But Dr Groden would know that the drugs deaths have reached an all-time high in this last 12 months. And I wouldn't like to begin to visit the numbers that you've just quoted there in terms of costs and so forth. I think that there would be guessology rather than science. The question really that we've posed here is not so much where are the benefits in terms of financial savings and crime reduction and so forth. It's where is the collective strategy on all your parts in reducing the problem. So, okay, let's just accept all that you've said is true, and that's been a plus for us. How do we begin to deflate this problem that we seem to accept as just part of life? How do we get all these words that we've just talked in this last 2 hours or hour and a half or whatever, how do we make it have impact on this group rather than merely manage them?
You want to answer that before I go back to Dr Graham?
I'm happy to come back and answer that. I mean, I think there is a big opportunity, and I accept it takes time to influence the change, but having a continuum of service, and I'm a GP in the East End of Glasgow, so I see these individuals both in the prison setting and out with the prison setting, and they don't change. It's the same people. That there's a revolving door. You talk about further sentencing and readmission rates to prison. In actual fact, for a number of these people, it's actually outstanding warrants that they're readmitted to prison for, and not because they've committed a further crime, but something that they've done prior to their previous admission to prison. So there's something within that for me, in my experience of seeing these people, because they come in and see me in my practice, and then I don't see them for 3 months, and then they reappear. Now, we have communication from the prison service, and I think we've tightened up the kind of continuum of care within the prisons, with better contact with GP practices and those delivering the service in the community, both at the point of entry into prison and when they're released from prison as well, to ensure that they have a continuation of service, because that's when they're most vulnerable, is when on release from prison, to ensure that they continue to receive care and appropriate care within the community setting, and we don't any longer let them go out and try and find their own GP who may or may not be willing to prescribe methadone for them. It's a very planned release that they have in order to ensure that that's better. So I think there's an opportunity there, because we are managing and we're involved in delivering the continuum of services to these individuals within Greater Glasgow and Clyde. I think the biggest challenge is actually, as Mr Gibbons said earlier, when people are moving around the country, and then there's a real difficulty in accessing services for them, because we're not familiar with the services throughout the country.
To what was mentioned earlier, this absence of, for lack of a better language, performance indicators that reflect or otherwise that reoffending is reducing. The absence of that is quite incredible.
Absolutely accept that, yes.
So what do we do about it? Dr Graham.
Thank you. Well, I think I can't answer the comment about the lack of progress. That's really been the Prisoner Healthcare Network that has been taking that work forward, and they're not represented here today. I do think that we have moved forward, particularly on the alcohol front, in terms of what works, the evidence, and a way forward, and we're continuing to push that. So I do believe that that's the case. I do agree that the evidence is on outcomes and prevalence of problems is not only, some of it is there, as Ms Logan was saying, but it's not comprehensively brought together, and it's not complete. I mean, that's something I really would like to see happen. In terms of reoffending, there is the potential to bring those two together through linkage, and that is linking the prisoner record system with healthcare systems and mortality, which is the basis of which the work that I did whilst I was in the Scottish Prison Service. When I went back, by this time back in the NHS, to explore whether I could do that for monitoring the Scottish Government naloxone programme, those permissions weren't there. I could only do that whilst I was in SPS. So although ISD has been working, we have to go into the Scottish Prison Service and manually search records, which is very laborious. So I think there's some work to do on information sharing protocols between the prison service and the health service in order to be able to look at what I think are common goals. I see a way forward, it's just getting there.
Good. Yes, and well, I'd like somebody to comment on that, because it seems to me that shouldn't be difficult. So could somebody from the prison side, tell us how we go about that? Yes.
Probably just to explain where we were prior to transfer in terms of healthcare records, in that we relied heavily on a manual healthcare record system. Therefore, it's very difficult to actually gather and interpret information because it's manual. With the introduction of Vision, which came in on the 1st of April this year, there is going to be a more consistent way of actually recording health information, but there's still a wee bit to go yet in that development. They probably still don't have the software designed to really gather the right information in terms of mental health engagement, in terms of addictions engagement. It's also not used currently in terms of prescribing, so it's still a manual prescribing system that's in place. There is developments in place to put this in place in terms of the IT system, but there's still got a wee bit to go yet. In terms of performance management, I think we'll have to wait for the network in terms of the work stream for performance management to pull together those indicators and try and get a consistent model to record information.
I'm breathtaking that it's still manual prescription. Sandra, it's
thank you very much.
On that particular point, so I've got Jenny and Rod waiting.
No, sorry, just on that particular point, because that was obviously the first question I asked, how difficult it was. It seems to be that with the NHS and the prison service, we're looking at records at the moment draft. There is a movement towards it, but obviously the suggestion is that the IT system has to be improved, and I would like if perhaps the committee could perhaps even write to Justice Minister or chase that part up about the IT system, because I think we need to have the records together, and it could be a real improvement if we...
That would follow up from our roundtable discussion. Sometimes in roundtables, little bit of gems or little bits of issues float to the surface, and that's one that I think is one. Let me have Jenny and Rod in now, and then I'll take the other witnesses. You've been waiting quite a while, the two of you. Jenny.
Thank you, Convener. I wanted to ask about speech and language therapy provision within the prisons. This committee did a roundtable evidence session a few weeks ago now, looking at the issue, communication issues that prisoners have to do with their language skills and confidence and all sorts of related things. Can I ask what the provision of speech and language therapy was before the transfer, and what are the plans for speech and language therapy post the transfer?
I don't know if I know the full details, but I did know that there was a speech and language therapy service available at Polmont, and I think they had a call-in service at Inverness Prison. I don't think there was much more in terms of specific speech and language therapy services as a consistent service. However, in terms of addressing needs, specific needs, if someone was requiring a specific need, I'm sure that the health service colleagues would have engaged and tried to get that service brought in. But in terms of providing a consistent service, there was a service provided at Polmont, and there was a kind of call-off service at Inverness Prison. That was prior to the transfer.
Before I get back in, Jenny, I've got the same question, Dr. Smith and Mr. McEwen coming in as well. So you want to comment before Jenny comes back?
I'm going to confine myself to commenting on the post-transfer aspect of it. But what I would say is that services from allied healthcare professionals, which would include speech and language therapy, physiotherapists and also occupational therapists, have been noted to have increased and improved since the point of transfer at Shotts Prison in Lanarkshire. But much of this is done on an individual assessment need. So if one of the clinicians who's closely managing these patients identifies that there's a need for one of these professionals to become involved in their care, then they come in to provide that care.
Mr. McEwen.
Exactly the same point, actually, in terms of that's what happens in Grampian. But just as perhaps to cheer Mr. Pearson up, I have to say I'm doing a review of all services at the moment.
Task, but go for it.
I'll have a go. I'll try my best. I'm doing a review of all the services that we currently provide in preparation for HMP Grampian, which opens at the end of the year. And exactly as you said, in terms of the allied health professions, we've looked at what went on before, and it was the same situation where it was almost as required, and generally to do with swallowing type issues for speech and language specifically. What I have to say, in doing this exercise, and this applies to mental health, substance misuse, the whole range of services that we're providing, I have absolutely no problem in engaging fellow professionals in this area of work. And if one thing the transfer has done, it has raised the status of prisoner health, if you like, higher than I've ever known it in the last 4 or 5 years. So while some of the things may be frustratingly slow in the first year, one good thing it's done is really raised the profile, I think, nationally across the health field. I mean, I have absolutely no problem. Yeah, no.
That as you go
well,
around
that
prisons.
wasn't a smile, but it was close.
As good as it gets.
I mean, at any level, if I ask for engagement in terms of a medical input, it's the medical directors pushing each other out of the way to get there. It's the same with dentistry, psychology and so on. So I think there's a very positive vibe around about prisoner health at the moment.
So Dr Smith and Mr McEwen, you both saying that in your areas there are speech and language therapy needs assessment done of every prisoner in your care? No.
When an assessment is made of anyone who's in the prison and it's thought that they need input from any particular type of professional, then those professionals come from the NHS family in to provide care.
Okay, and how does that assessment come to be made? Is it on admission to the prison?
It would become... Well, I've got to speak for Shotts prison here, because Shotts is slightly different from other prisons in that it deals with a long-term, very stable population there. Yeah. So as healthcare needs arise, or as people are assessed at their admission procedures, if you like, a care plan is made for each individual, and if you like, the relevant professionals who would be involved in delivering that care plan are identified and brought in to deliver care.
Gibbons wants to come in about,
Can
I think, about just on the same point about assessments.
Can I just clarify something that
okay,
Dr.
then,
Smith
Mr Gibbons,
said?
yeah.
So you're saying as a healthcare need arises, so it could be that a prisoner is ill and therefore is taken into the medical wing and is given a health assessment, and at that point a wider assessment might be made. But conceivably from that point there could be a prisoner in Shotts prison for 10, 12 years that perhaps has a very bad stutter or stammer that perhaps speech and language therapy could help out with, but that needs assessment is never made. Is that correct?
I would I would suspect that needs assessment would only be made if the problem was brought to the attention of the clinical staff who were working in the area.
Is there scope within the transfer to, the NHS has come in and the whole system has been transferred over to the NHS? Is there scope or budget to do a whole healthcare needs assessment of every prisoner in the system?
I think that the fiscal results of that would be quite challenging.
Mr Gibbons.
I was only going to make a similar point in terms of when prisoners are admitted to prison, that's where they would normally pick up if somebody had a specific need, or on one of the ongoing clinics they could refer to see the GP or the nurse daily, and if they raised an issue, we certainly would engage with any specific services or specialist service for prisoners. That's how it would normally work.
Is this on the same issue, Mr McEwen?
Yeah, I mean, I think there's an assessment of every prisoner anyway, because they come in and they will see certainly a nursing member of staff, but they will all see a doctor within the first 24 hours. So there is an assessment made of every prisoner entering the prison system. And that would be the first opportunities to pick it up. Then there's obviously ongoing monitoring of prisoners, both by them referring themselves and by the general monitoring that goes on by the nurse staff within the prison.
Yes, certainly, yes.
Can I go back to another point? Sorry, it's just on the point about raising prisoner health care, and it has never been higher in terms of a lot of the managers who work in healthcare in the prison feel that the NHS coming in has actually empowered us, or empowered local management to actually to push for change that's been difficult to change by being a part of SPS. So that's sort of been a positive sort of step. And lots of the posts that are coming up in learning disability, for example, alcohol services, they're appointing, certainly in Glasgow, they're appointing people to look into improving services for people with learning disability and alcohol needs. And part of part of that improvement is actually to try and carry out some quality research as well. And I feel for somebody who works in the prison, and some of my colleagues care passionately about the people that they're trying to care for, I feel some of the research that's been done in the past is based a lot in England and Wales and here, there and everywhere. And there's not a lot of quality research based in healthcare in prisons, just historically. And I see a vast improvement in that coming. And when that starts to take place, I think we'll be in a much better position to actually form action plans.
Well, I was going to, yes, and then I'll take Rod after that.
Comment on that point. It strikes me as, I don't know, you're talking about the data and available data as well, that the NHS coming in to provide the services, an ideal opportunity to actually create that evidence base and that data by doing a full needs health assessment of every prisoner in our prison population.
Yes, Dr. Graham.
Just using the alcohol problem as an example, I mean, as every prisoner was coming in and was seeing a nurse on reception and a doctor within, I think, 24, 48 hours, there is that assessment. But for alcohol, the question was being asked, have you got an alcohol problem, aye or no? And that was it. What we've tried to do is say, well, that really wasn't enough because that wasn't unearthing things. Use a proper validated screening tool. It doesn't take very long. That's the recommendation we put forward in the model of care. But we also recognise the timing of that assessment is important as well. And when a prisoner comes in, that's not necessary. Oh, yes, I've got a bit of an alcohol problem. Isn't the immediate thing in the top of their mind. So I think it's similar for learning difficulties and speech. So is there a validated screening tool built in to the assessment process? And it may not necessarily need to be or appropriately be at the point of admission, but at some point. I think it's a sort of similar situation, I think.
Can you just develop recommendations? You're going to put these forward when? You mentioned a recommendation of having a better series of...
For alcohol problems?
Yes.
Yes, that's the research which is reference 3, Prison Health Needs Assessment, which was published 2 years ago and which we've been driving forward with Health Scotland, with Scottish Government, to promote that agenda with both the alcohol drug partnerships and the community justice authorities, and indeed had a big meeting just last week again. So we're trying to promote that along with what Ms Parker's been referencing as joint working, getting pathways in place. So there is a lot of work at the moment going on to push that forward.
I'm getting past words like pathways. I know I would get into all this jargon. I'm not blaming you, but So what you're saying is you get a recommendation that the series of questions that are asked at the assessment that Jenny's referred to are more pertinent instead of just an aye or no. But you actually get and when would that? How can that not just be put into practice? What's the problem?
That's up to health
SPS, yes, Ms Parker.
That's what I mentioned earlier about the review of and redesign of services that's happening across Scotland and health boards at various different stages at this time. Forth Valley was the health board that I cited as being actively involved in that, and they are taking forward the advice recommendations from the research to include a more robust process at the admission stage to be able to identify the significant needs, particularly in relation to alcohol, and be able to respond to that with appropriate interventions.
So where is this going to end up? Who's going to be sitting in a group, and when is it going to actually be done?
That will be done at different stages as health boards take that forward as part of the redesign of their services. I can only speak for the one that I've been actively involved in, which is Forth Valley, and they're looking to take theirs forward probably 2013.
Next year, right, next year.
It's in draft form.
On the same thing, Mr Gordon, is this the same?
Yes, well, it's just to also highlight the Keep Well checks that are currently ongoing within the prison establishment, which is part of the national programme of Keep Well, which actually will cover such things as alcohol use. I think one of the challenges is always people coming forward for these checks. I mean, we are dealing with a voluntary participation in these assessments as well.
I wanted to keep to the question that Jenny asked, is the questions that are asked when prisoners come in for that assessment, even returnees, as it were. And it seems that some simple things could be asked to get on a real answer rather than a fantasy answer. I mean, is there any other comments from Barlini, so on? What happens? Are they asking the right things?
I think the admission process and the questions asked are fairly comprehensive, but there is a need to come back in and review what is said at admission and then provide a more quality time with guys coming in or with ladies coming in to prison. The admission process in itself is a very, very busy process. For example, on a Monday between 6 o'clock and probably 11 o'clock and sometimes midnight, Barlinnie can be receiving up to 100 prisoners coming in from the courts. And if you can imagine how quick those or how fast those admission processes are taking place. Guys are coming in, they're fairly apprehensive, they're quite worried about what's going to happen in front of them. Some of them haven't been in prison before. It's not the right time or place to provide a quality service. You're trying to make sure somebody's safe. If there's any major issues that are life-threatening, you're picking up whether the guy's diabetic, whether he's got a nut allergy. All sorts of things are picked up at that, and it's fairly robust and works fairly well. We know that. But to do some of the actual qualitative type work that's needed to follow that up, you need a sort of process coming in behind that. And I think it's forming that strategy that's needed, because and I think Mr Pearson is right. I think there is a bit of work to be done on that model, but people are striving to try and get there. And I don't know that there is national. That's another thing that's sort of odd if you work in Greater Glasgow, whether there is a national strategy across health boards, because there may not be. What's suitable for the Highlands and Islands might not be suitable for Glasgow and how they approach certain things. So it might be that the approach will be slightly different in different areas. Long-term prisons, for example, take people who have already been in Barlinnie for a year and their health problems are pretty much sorted before they go there. They may develop problems there, but in local prisons, the actual complexities and the speed at which things are happening is very fast. And when you talk about a full assessment of prisoners on admission, you have to also remember some of these guys might only be there for 14 days and away again. It's very quick turnover.
It's certainly been on admission.
Yeah. So, but you're right. I think for people who have stayed with us for any length of time, we probably we need to quite quickly develop models that meet the needs of different prisoner groups.
Just to follow that, I'll let Rodney. Could you then share that if that's done in the prison? Is there some barrier to sharing that data with health?
No.
None. There's none.
No.
With the NHS who are providing the service, this linkage. Dr. Smith, and then I've got Rod.
Yeah, I mean, I think it's an interesting observation. In a former life, I was a GP, and one of the things that I was aware of at that point was that prisoners who came out of prison they came with very little information about what happened in terms of the medical treatment during the course of their stay. I think with this move, that there offers an opportunity to try to take a much more integrated approach to this. There's one word that I've used in all the approach to the transfer of prisoners' healthcare, and since that point it's consistency. What we have the opportunity to do now is to ensure that we offer the same approach to these very high-risk individuals, whether it happens in the community or whether they're seeking care in the prison. And soon we'll have the same opportunity to, when opportunities arise in police custody as well, because it's the same service, it's health that's going to be responsible for looking after them. We'll be able to communicate more effectively between the different aspects. And I think if we go touch upon some of the kind of concerns that were raised around about addictions, by making the alcohol and drug partnerships that exist in each board area responsible for the delivery of care to these people, we're going to get a consistency of approach, not only within a board area in these different environments, but actually across the country, because they're all following the same national strategy. So I think that there is tremendous opportunity, but I think it is also right that that opportunity is measured in some way, and we need these performance indicators to underpin that.
Odd.
Good morning everyone, just wanted to talk about prisoners coming out of prison, and Leslie Graham's talked about mortality rates and saying the greatest number of deaths occurred shortly after release. I don't know what kind of further information you have as to the causes of death, and if we have a kind of NHS within the prison, what we're aiming for is as a seamless transition as possible coming out. Perhaps you could just tell us a bit more about your conclusions on those mortality rates.
I think just to paraphrase your question, is it when prisoners are coming out and dying, the ones that are dying within a very short space of time, what are they dying from?
Yeah.
Well, research, it's not, as I say, a routine reporting system, unfortunately. Research has shown that predominantly that is the other causes of death that I've already mentioned, which is drug-related mortality. Although I'm happy to see that following, we've been monitoring that with the Scottish Government naloxone programme, because one of the monitoring indicators for that is looking at drug-related mortality in those who've recently been released from prison. And Ms Parker will be able to back me up that the numbers are now, I think, have been falling over time. But this is all sort of fairly emerging. So it's drug-related mortality, suicide is noted to be high as well, and also alcohol-related mortality.
How far do you think, in terms of preparation for discharge, we could do more to tackle some of these issues?
I don't think I'd be able to. I'm not at the sort of operational sort of front of things. So certainly, just from first principles, as an ex-GP, for those with alcohol problems, obviously that's a very artificial environment to some extent in the prison setting. Going back out into the community is a challenge in many ways, whether it's re-establishing relationships, employment, etc., housing. There is a high risk of relapse into heavy drinking. So I think more needs to be done, not only on through care in general, looking at all those elements of housing and so on, but specifically focusing on the alcohol. What could be done to prevent relapse? So there's various intervention strategies around that. Drug-related mortality, there is a naloxone programme in place in the Scottish Prison Service which issues naloxone kits. That's an anti-opioid antagonist which prevents or can reverse the effect of overdose. So there's work on that front. Mental health, I don't know what in specifically is being done on that front.
Rates of death are going to be falling, that we're going to see an improvement in statistics?
I wish I could repeat that one-off piece of research. That would be, that's the way in which, I had a sort of a vision, if you like, which would be to have a sort of prisoner healthcare database that you could run those figures at any one time. But that would require a linkage between the prisoner record system, that's not the healthcare record system, the SPS, and the various healthcare records, not only those that are in the vision system, but you could link it to hospital admissions, you could link it to mortality, and then at any one time you could answer those questions, but we don't have that.
I think, because we're running on time, is that I know I've got Alison, Graham and John. I wondered if you'd relinquish your chance, just unless you feel you have to at the end, because I was going to ask everyone if we were to we're going to consider perhaps doing a short report on what one thing you would want to see included in the report from what you've heard today and from your own aspect that we should really be looking at. So one, not one thing for us to do, but one from each of you that you feel we should perhaps address the issue. And if I could just come round the table, and then if the members feel there's something I've missed, please let me know. Ms Pate.
As a follow-on from the dialogue that we've just had, that I've not had the opportunity to come in on, I think what I've heard is people speaking about speech and language problems, alcohol problems, drug problems, mental health problems. Different organisations get different funding streams to do different things and therefore tend to report on different issues. So you'll have an individual person, we're talking about prisoners, that they are citizens who have a whole broad range of problems, and we tend to report on individual problems, and that's not the reality of that individual's life, because they live with those problems all the time. I'll try and be brief, but I think the point that I'm making is that I absolutely agree we should be able to look at offending outcomes for people, but we should also be able to talk about improvements in their mental health, improvements in addictions, how they live their lives, how they function generally. And at the moment, our funding streams are such that we don't report in that way. Through our national outcomes rather than a national strategy, which we all report on national outcomes through our CJAs and our heat targets and such like, I think actually the leadership here is coming from the Justice Secretary's support for the Women Offenders Commission recommendations, that we start to work with people as individuals in places where they get access to the whole range of services that have been picked up on. So instead of people having to report on outcomes specifically to the way they are funded, that we can start to report on outcomes for individual people, and that those are very varied and that they're complex. And we do recognise, we need to start recognising the complexity of the problem that we're working with this individual group. And my last plea would be that if anybody does get together to look at measurement tools, that we don't forget the specific needs of women within that population, because we need to ask different questions about mental health and different questions about trauma.
I think the committee is well aware of that. As you know, we've paid huge attention to the specific area of women offenders. Ms Logan.
The one thing I'm going to plead for is to continue to have a partnership between statutory and voluntary organisation in the provision of care and support for prisoners.
Thank you very much. Dr Graham.
I think probably know what I'm going to say, which is that I would like to see progress and on being able to measure the health and healthcare needs of the prisoners and the outcomes, not only health but reoffending. There's a long story.
Oh, well, we haven't got time for it. You can write and tell us. I take it also research. I think the comment picked up on that it was UK research or English research, apart from yours, obviously.
Yeah, I mean, evidence, if you like, can be got from routine reporting. It can be got from ad hoc pieces of work, like surveys, like the prisoner health survey, the prisoner survey rather, and from research. All of those are important in their different ways.
Ms Parker.
We discussed through care. I think there's a real opportunity to have that circular model of through care, where not only do we make referrals to community services, but we also have feedback coming back in to inform wider outcomes. Also the issue of health and the work that the health boards do and how that can be used to track individuals in their recovery throughout their sentence and back into the community, and how health outcomes can inform justice outcomes in relation to reduced reoffending.
Would it be possible to have some kind of background paper on what Forth Valley is doing?
Certainly.
That would be quite useful. Yes, Mr Wilson.
I would like to see just a wee bit more improvements in terms of data sets, and increased improvements in terms of the software for vision, which is the IT system, and I think that really needs significant development so it captures all types of health interventions in prison, and then it will permit the sharing of that information with community partners.
Much, Dr Smith.
I think now that with the establishment of a good IT system within it, I'd like to see the kind of central identification and agreement around about the data that we would want to collate centrally and kind of benchmark ourselves against.
Who would do that? Who would do that?
I don't think it's beyond the realms of possibility, but it would need some central resource to coordinate that.
Mr McEwen.
I think there's a lot of really good stuff going on in separate health boards that's not just joined up across health boards, so that's probably what I'd like to see. And I didn't get a chance to elaborate, although I'd put it in my submission, particularly in the use of telemedicine. I know that Tayside are doing teleneurology for prisons. I know that Lothian are doing a forensic psychiatry through telemedicine, and in Grampian we're certainly looking to do the unscheduled element through telemedicine. Those are just one example, one field how we can improve the service. But some way in which all the good work that's going on in separate health boards is drawn together is probably what I'd like to see.
How would you do that? How would they do it? Health boards, don't they meet and share?
Yes.
Through the network, I think.
Through the network.
Yeah, there's a prison health network, and I think we need to be a bit more active in sharing good practice.
Okay. Mr Gibbons.
Yeah, I think it's a good opportunity. We're at a place where we could marry some of these ideas and form a model to take forward that would be very positive. I think politically as well, people shouldn't be put off some of the strategies that already exist, because I have found and my colleagues have found have been very effective. Substitute prescribing, for example, gets a very sort of negative name in terms of cost and stuff, but I still remember the prison service pre-substitute prescribing where conditions for prisoners were awful, and some of the deaths through suicide and self-harm were much higher than they are today. They're much, much lower than they were 10 years ago. And some of these strategies, we shouldn't throw the baby out with the bathwater in terms of it has to be a measured sort of approach, and some of these strategies are very effective that we have in place at the minute.
Mr. Gordon.
Yeah, I mean, I touch on through care as one of the key areas, but coming up with something different, I think we need to look at some of the processes that we've inherited around the prison health care that we have to do as a matter of agreement, and actually take up a lot of resources that could be better channelled, actually delivering care to individuals rather than just processing people through the system. And I think until we get some national agreement around looking at what processes we need to do and those that maybe we could do in a different way or dispense with, which we've done historically, we're always going to struggle with having enough resource, enough bodies to actually deliver the type of care that we're all aspiring to and that we've heard about today.
If we were to return to this, this is just an investigative roundtable for us, exploratory. If we were to return to this matter, when should we sort of summon you back, as it were, where things will have moved on? How you're talking about the board speaking together, you're talking about IT systems, etc., etc., and we may have our preliminary thoughts on it, but what timescale would be a timescale to see if issues had moved on? Well, I mean, we can all talk forever, but let's get some progress, yes.
Well, I would suggest that I think you should set the targets, given that you are the Justice Committee and you want to see change. If you want to see change, you should set the targets around that. But I think a realistic target would be to see progress within a 6-month period.
Six months. We must think alike. Yeah. I was thinking 6 months. Yeah. So I think that's interesting, because I think that having had this, we'd like to perhaps ask the same questions in 6 months' time, look at the record that we've done now and see whether we're getting the same answers. Now, does any of the committee feel there's something they were itching to ask and wasn't asked, or we may move on? Alison, yes.
Sorry, I know you do want to move on. I wanted to pick up on something that the Chief Inspector of Prisons has regularly reported on in his reports about Cornton Vale and about mental health issues, complex needs of women there. And he's often commented that there are people in Cornton Vale who ought to be receiving treatment elsewhere, and there were clearly constraints within the old system. I would be interested in what capacity there is in this new provision of mental health services to be able to deal with some of the most complex problems in Cornton Vale elsewhere, and whether or not there is enough dialogue to make that happen. I appreciate we have no one from...
Yes, Mr Gibbons.
So that just in a sort of broad sense, I'm not actually directing an answer in relation to Cornton Vale, but one of the things that the health boards are looking at in relation to managing people with complex needs is actually training and education for both prison staff and for nursing staff. And when I say nursing staff, I mean non-mental health nursing staff, like general nurses, because we have quite a high population of people with behavioural issues who create lots and lots of problems, and particularly around personality disorder and borderline personality disorder. So there's some money being invested in that in health boards and specialising and getting some training for staff to help them manage people and improve managing people better. And I think that will make a significant difference. Also, there's also plans now to link in with the duty forensic psychiatrists so that we can get out to other services and things that would help us to deal with emergencies and getting people to hospital fairly quick. One of the things that I thought that NHS done quite well before the transfer was that we were able to identify people who have got acute mental illness and get them into hospital, but where there was doubts about their behaviour and personality disorder in particular, it was always quite a difficult issue. And I can see huge improvements being made there, just even in the way that they have knowledge base that will help us manage people better who maybe won't be best placed in hospital but could be managed better in prison.
What I'm going to ask Graham and John to do is to put your questions on the record, because I want to move on, and then I'll ask witnesses to respond in writing to your questions, just so we can move on. I want to have everybody get the chance. And any fuller response to Alison's as well, please just write. You'll be able to read the report in a few days. Just your question, Graham.
My question might get a one-line response.
Well, don't preempt.
And it's for Ruth Parker. HMI Prisons has reported that the Dumfries healthcare services operate under difficult conditions. Is it within the system that someone within your organisation picks up on that comment, and are they going to work through what those difficult situations are and repair them?
Don't bother, that's the question. It's not going to be a one-word answer. Certainly not. And John?
Thank you, Convener. My question was to Mr McEwen. It was about his comment about, in common with other health boards, Grampian has promoted the re-registration of prisoners returning to communities among GP practices. I recently dealt with a situation where 3 practices were declining to register people on the basis that they didn't have photo ID. That's since been resolved. I just want to know, are there difficulties elsewhere? Thank you.
That's it. These are the questions on the record, and anybody who wants to answer them, just please write to the committee. Can I thank you very much for your attendance? It's been extremely interesting. We didn't expect solutions today. We just wanted problems, and we've seen there are some, and if you've got others we've missed, no doubt you'll let us know. Thank you very much. To the committee, I'd simply say I think we should maybe discuss next week whether we write the Minister with the issues or whether we decide to write a little report for ourselves. Can I leave? I think there's a lot to read. So perhaps rather than decide something today, leave it till next week. You content? Right, thank you. I'm going to suspend for 8 minutes. Thank you very much. Okay, we'll start back. And item 2, HMTV Inspector of Prisons, your annual report. And we're getting evidence today from Brigadier Hugh Monroe. I welcome you to this meeting, and I know you sat through the whole of that last bit, albeit on a very uncomfortable chair. We shall do something about that. Anyway, this is the first time the committee has considered the Chief Inspector's annual report, but not the first time, of course, the Chief Inspector's appeared before us, and I welcome you back. Now, can I have questions from members? This time it's your turn, members. So, Rod?
Good morning. Could I just kick off by asking you a bit more about the personal officers scheme, which you referred to in your report and indicated wasn't working very well. Perhaps you could give us your view as to why it's not working very well and what steps could be taken to actually improve it.
Yes, thank you. Good morning. And it's thank you, Convener, for inviting me here. It's a great honour to be asked about the annual report. And Roderick, thank you for your question. I think personal officers absolutely goes to the whole heart of what the prison service is about in terms of rehabilitating prisoners back into the community. I heard something on the radio this morning about mentoring of prisoners and delivering prisoners out from prison back into the community again. And I think this is very much the prison service's contribution to this, if you like. And by the way, it's free because we are already paying for prison officers. So in my view, this is a service that should be provided. It's a service that I know everyone in the prison service has agreed to do. And yet, in almost every prison I go to, I don't see a number of things. First of all, that prison officers have been trained to do this job, and I think it does need a bit of training. Not all prison officers are ideal fits, if you like, for this sort of mentoring support process. So I think there is something here that can be done in terms of training them and encouraging them. And I think that is an important aspect. And I think it's a main reason why it doesn't work very well. The other reason is I don't think that managers, both in halls and unit managers more widely, are prepared to supervise and lead this in a way that I think would make a dynamic difference. If we put all that together, I think you would have a much better system. I also, sorry, there's one other thing I want to say, is that I don't think this should just be confined to those prison officers who work in the residential halls, which is currently, I think, the main practice that's intended. I think any person who's working on the staff in a prison may have a particular attribute that makes them effective in this way. And I think there needs to be not only a training process, there also ought to be a selection process as to how this is best done. If you put all that together and you have a properly trained and selected staff that's properly led and supervised and is measured, I don't see nearly enough measurement of progress in terms of who's doing it, who's looking after what prisoners in the most appropriate way, and then how do those prisoners do both within prison? Do they go to work? Do they go to education and so on? And by the way, what are their connections with their families and how are they going to progress once they get back out to the community? So there's rather a lot there, but I think it's absolutely fundamental to what the prison service should be providing in terms of rehabilitating prisoners back into the community.
Scottish Prison Service Board will be receptive to these comments with the new Chief Executive?
I certainly think so. I think that in terms of the context of the report I've delivered, which is the third in the four I'm to produce in my period as Chief Inspector, what's clearly happening is we've got a new leadership of the prison service. And I think in terms of the context of today, this is a report that was on last year, as it were, up until April 2012. What we've seen in a way since then is a real difference in the way that I think the prison service is intending to go with the appointment of the new Chief Executive. So my personal view is once the governance of the board is sorted out, and I know the Chief Executive is keen to do that, once we see how the board intends to take these sorts of issues forward, I think we'll see a much bigger improvement in the way this is done. And I also think that there will be an improvement in the way that the training and development of staff will deliver on this. But I should say, and I think this is a very important part about the context of the Chief Inspector, I only inspect what I see. I don't inspect good intentions or strategic plans or whatever. I inspect what I see. And I think in terms of this question, but a raft of other questions, I guess, I can only tell you what I see in the evidence that I gather.
Does anyone else want to ask on the same topic? Preparations for release and so on? No? Right, I've got John.
Good morning, Brigadier Renault. I'd like to ask you about legalised police sales, if I may, please. As a representative from the Highlands and Islands, all but one of those is in the Highlands and Islands. Can I ask you about the level of use that you understand takes place of the sales for that specific capacity as a legalised sale?
I just missed it.
The level of use that you understand is made.
The level of use is relatively low, which is why I have recommended a number of police cells are closed, because I don't think they are relevant. And I think the reason is that the use of is the contract for escorting prisoners from normal police cells to the appropriate prison. Now, clearly, in the case of the Highlands and Islands and indeed the Northern Isles, there is a logistical problem which may be compounded by poor weather. And I think for example, personally inspected the Kirkwall. I know that's not in your area, in the Kirkwall legalised police cell. As far as I remember off the top of my head, that had hardly been used in the previous 12 months. And so, but that doesn't mean to say it shouldn't be there. I think this is purely. I think it's very important that where it's relevant and where it's geographically sensible, then those cells should continue. I don't know if that's getting to the answer you wanted.
Yes, it does. I mean, the logistics of prisoner transfer are important, and I wonder, therefore, the recommendation to dispense with Lochmaddy, given that it's what we would refer to as the Southern Isles of the Western Isles, obviously, and the challenges that are quite often the case there of getting off the island. Why particularly recommend that ceasing to be?
I think the level of use at Lochmaddy, and I think I need to come back to you on this issue, is the level of use there was particularly low, and that there was a feeling that you could transfer and fly them out if necessary. But I think I need to come back to you, if I may, Mr. Finney. I think that would be a sensible thing to do on that particular issue.
May I ask a couple of others, please?
Yes, certainly, yes. There's nobody else with supplementaries.
Brigadier Monroe, the comment about exercise outdoors, do you understand? You'll follow up on an inspection on that, presumably. Are there record keeping about people being exercised in fresh air?
Yes, indeed. Where we make a comment about such as that, we would follow up, and I would expect the Scottish Prison Service to run an action plan on each of my reports, and we will look at those action plans. So if we've made a comment about a particular prison in terms of exercise outdoors, we will follow that up, and either formally by going back to a prison to re-inspect it, or informally in terms of keeping an eye on the action plan and then visiting the prison just to double check. So I hold great store by outdoor exercise and whether people are appropriately dressed and so on. And so I would go back and double check that.
And finally, please, are you content the lines of responsibility for someone who's in a legalised cell? Who is responsible for them?
I think I need to come back to you on that before I give an answer. I will come back to you on that. That's on particularly the legalised police cells. Yes.
Yes, indeed. Thank you very much.
Thank you very much. Just right to the committee, please. I've got Graham, followed by Alison, Sandra, Jenny and Colin.
Thanks, Convener. A different issue. Sex offenders. You make specific reference to what you called a penal cul-de-sac, and you referred to Dumfries Prison particularly, but I think that anecdotally, there are other cul-de-sacs within the prison estate. Given that the general public are vexed by the threat that sex offenders provide, and that the evidence is that sex offenders can be prolific in their offending when they return to communities. Do you have any comments that you would make about the way forward in managing and dealing with sex offenders? Are you concerned about these cul-de-sacs creating new networks, new associations amongst those who offend? And you mentioned the reoffending programmes that are utilised within prisons. Do you have any evidence either indicating the success of these reoffending programmes or otherwise?
Can I start off with the penal cul-de-sac, which I was specifically targeting at Dumfries, because these are sex offenders who are refusing to admit their guilt, and they have been sent there for that reason, and therefore they were not getting access to sex offender programs, which at that time were being carried out in Peterhead, but now are carried out in Glenocle. I felt strongly that this was not a healthy way forward, either for those sex offenders or indeed for the staff and the prison as a whole. What I was trying to get at was for the Scottish Prison Service to produce a strategy for managing sex offenders, which at that stage was not even in draft. And I felt that all we were doing was shipping the awkward squad down to Dumfries, which, as I said, I don't think was healthy. I'm pleased to say that I think that has changed, and that there is certainly a draft strategy. I need to go back to Dumfries, which I'm doing in January, I think, to double check that there is some movement forwards out of this. I think, just to address this penal cul-de-sac business, I think there has to be, I go back to the point about mentoring. This is where I think there is a danger we just put certain prisoners into a place and leave them there, and we secure them, as it were, which is fine, but it's not trying to motivate and lead and progress these people. Because what I really worry about is at some stage, offenders are going to be released from those conditions directly back to the community. That doesn't seem to me to be a very sensible way of progressing, when actually what they should have been having is the benefit of a sex offender programme that would challenge their behaviour. And then I have a question mark, and I don't produce solutions, merely the questions, about at what stage do we test, in inverted commas, sex offenders in open conditions? How do you do that without raising the risk, certainly in the public's perception, but in the reality of putting sex offenders in the public domain? But the counter to that is, if you just release sex offenders directly from closed conditions, is the risk not just as high, if not higher? And so I have asked the question, and I take account of the MAPRA arrangements. I'm perfectly clear about those, and I think in Scotland, I think we try and deliver those pretty well. But I think there are a lot of questions here to ask about not just the penal cul-de-sac, but how do you get sex offenders back into the community? And that takes me on to the last point you raised, which is the business of sex offender programs. Because I can't tell you, and I haven't heard anyone tell me, to how effective these are in terms of actually dealing with sex offenders and challenging their behaviour, and then measuring whether it has indeed been worthwhile or not, and what the reoffending process is. I think sex offenders are extremely difficult to understand. I think the public find it extremely difficult to understand. That's why I think we need a bit of clarity on this. That's why I would really like to know more about risks and whether we're raising risks or how do we lower risks. Are sex offenders, and I don't know this, I'm not in any way trying to be an expert, are sex offenders rather like alcoholics? In other words, abstinence is good for you, and you're going to get that in prison, hopefully. But once you are released, do you rather like an alcoholic visiting the pub outside the prison gates? Do you then, does your behaviour then go back to where it was before? And I don't know that, but I've never heard anyone explain it to me in a sensible fashion that's worthy of the public.
Do you get the impression from the Scottish Prison Service that they attach sufficient priority to the challenge that you've identified here, and that it will be responded to with the quickness of response that you would welcome?
Well, I certainly think we're in a better place than we were when I inspected Peterhead and Dumfries a couple of years ago. I think, obviously we've moved the offenders from Peterhead to Glenocle, and now they have got their own residential block in Glenocle, so they're in one place in Glenocle. And I think, and I need to go back and look at this, I think that is a better place than we were before. But I do need to, I do feel that this has at least been addressed by the Scottish Prison Service. I think there is a sex offender working group that is looking at this and trying to sort out this the cul-de-sac issue. I'm not in any way trying to suggest that this is easy, because it's not, and I find it very difficult to understand those people who won't admit their guilt and are resolute in doing so. But I think that's why I think we need to understand it better, and that's why we need a strategy, and that's why I would like to see staff trained to deal with this. I'll come back to staff training, I guess, on a number of different questions. But if staff were trained to deal with sex offenders, how do you motivate someone you don't understand in this aspect? How do you try and take them forwards? And I think those are big questions to ask. I don't know what the answers are.
Was there not a programme at Peterhead many years ago where you had special training and there was a special programme, and part of it was that the sex offenders, first of all, had to recognise they had committed an offence? Is that what happened to that programme?
The STOP programme, which was going on, which I think is the one you're talking about, then has moved into a Scottish Prison Service programme called the Good Lives programme, and I think we're there or thereabouts, is still very much in evidence. But what I haven't seen, Convener, is the evidence to show how successful those are. And that's where I think we're finding the difficulty in trying to understand and take this forwards. It's not only a training issue, this is a real through care issue, in my view.
Final point to you is that I would also acknowledge that this is a very thorny issue. This isn't an easy thing to resolve. So by no means in raising this issue do I feel that there's a reticence on behalf of the organisation to deal with it. But given the damage that these offenders do within our communities, ongoing damage for a lifetime, I would take it that you would agree that this particular thorny issue, difficult as it is, needs some additional attention, and this element of trying to measure what works and what is successful, and therefore when returning offenders to the community, how to assess the risk properly is an important priority that we should be addressing as quickly as we can.
Indeed, and I absolutely accept what you're saying about priority, because and that's indeed why I think we've tried to make it a priority. When I went to inspected Castle Huntly, the open prison, earlier this year, I was slightly surprised to find there were only, I think I'm right in saying, certainly under 5, and I think only 2 sex offenders in the open prison at that time. And yet we are releasing, I think, in the previous 12 months, I think somewhere around about 150 sex offenders directly from closed conditions, not having been tested under open conditions. Now, I don't know whether this is right or wrong. What I'm saying is we need some evidence and some help in this matter in terms of risk, as you rightly point out. And I think we haven't got that, and we need it.
Thank you. Alison, followed by Sandra, please.
Thank you. Good morning. I have 2 separate questions. Firstly, on Conton Vale, obviously you had your second follow-up report on Conton Vale earlier this year, and at that time you noted that unsatisfactory progress had been made and taken forward about 1/3 of the recommendations that you had had made. Now, obviously, since then, we've seen this radical change of heart, which we've all welcomed. But we need to caution against sort of saying, well, that's it all fixed. And there's a short-term problem still at Cornton Vale, and I'd be interested to hear what issues you still think need to be picked up. I was particularly concerned by the use of the silent cells, as you were. And I know that we now have a new separation and reintegration unit, I think is what they call it, but there was an over-reliance of use on that, and while we might have improved the fabric of that particular thing, if the mindset hasn't changed and it's still being used in the way that it was, that would concern me, and I wonder if you would share those concerns and perhaps more generally talk about what we still need to monitor at Cornton Vale in the short term.
Thank you. I think as we recognised at that session that I was at last time, the huge progress that's been made, and I was very interested by Kate Donegan's view about how the Women's Commission, and I hope also the Inspectorate reports, have changed the landscape.
Bit to do as well.
And the Justice Committee.
Yes, don't forget us.
I can't quite.
And Alison McInnes promoting it.
Yes,
very
no,
bring
I
it forward,
entirely agree.
So.
I think my the discomfort of my seat behind must have meant I reduced it. You better strike that from the record. I think actually your political support has been very important in this aspect. I was very interested in the previous session about the mental health discussion, because I think that almost in no other prison in Scotland is the mental health situation so stark as at Cornton Vale. I think in many respects because, I think as someone said earlier, that the women don't get into the services. They don't try and connect and sort out their own problems, and they're very much on show. And those of you who've been there and have been to Ross House, for example, it's a pretty discouraging scene. But I have been quite specific in my reports about mental health at Cornton Vale. One was in terms of the training of staff, and to what extent staff who are dealing with extremely challenging mental health issues are appropriately trained. I think there has been some progress, as indeed that second follow-up report indicated, I think in terms of mentalisation training and so on. But we are dealing here with really challenging people, and particularly those in the separation and care unit. And I think at some stage there's going to have to be a strategic judgment about those very, very challenging mental health issues and whether we're just prepared to put them into prison or whether they are sent off to another institution to deal with their issue, or whether we invest in appropriate training and facilities for prisons. And clearly one might, if one's going to build a new female prison, think about that. So I think there is an issue there about the training of staff and how you look after seriously challenging mental health issues. And then the second area we were involved in clearly has been the segregation of these challenging women. I have a particular concern, and when I did these reports, a particular concern about the so-called back cells, the cells in Younger House, all of which was utterly, utterly shocking and horrible, to be quite honest. And so to be in a position where we have encouraged and now we've got a new unit is real progress. But I question why it's taken 3 years to get there, given that a morning in one of those cells was too long. So I think there's a fundamental question there to ask. The other question about segregation is, how long should you be sitting in a segregation unit for? This isn't just a female offender question. There are women, as you know, and I know, women who've been there for over a year. Is that, in whose interest is that? It's certainly not in the interest, in my view, of the offender. It's not in the interest of the staff. It's not in the interest of Scotland, in my view. I think it's a shaming view, because essentially we are accepting defeat. We are essentially saying we have failed to take this person on either clinically or mentored and led them through to a better way. And I think there are significant questions to ask about long-term segregation of people with mental health issues. I don't know if that answered your question.
Yep, very thoroughly. And I mean, we ought to put it on record that I have no doubt that your reports, your 3 reports on Conton Vale, were what sparked the change of heart. And I think you are to be greatly thanked for the work you've done. I mean, it's my view that there's an abuse of human rights going on for these individuals who have been kept alone in the cell for such a long time. And I feel that we need to pursue that. And that's been a helpful response, really, in terms of that. The other question that I have relates to your report, where you pose the question, is it possible that the use of remand is increasing reoffending rates rather than reducing them? And it would be interesting to hear your thoughts a little bit more developed on that point.
Thank you. And I think it is a... we were at Clive Fairweather's memorial service last week, and it was him who produced that original report, which I referred to in my own report. And I think we should pay tribute to him for starting this off, because I think it is an interesting piece that we've got an increasing number of people who have not yet been either proven guilty or sentenced sitting in prison. And I worry about that. And as I say in my report, I worry about whether it's appropriate for them to be held in custody or not. I don't think any of us would fuss about them being held in custody if it was entirely about safety and security. If it's either in their own interest that they should be held in custody, or in the interest of the community that they're held in custody, I don't think I would be worrying about this. But I don't know how many of those people on remand fall into that category. If it is purely there for administrative convenience, that sounds a rather throwaway line, but I think we're talking here about people who are living such a chaotic lifestyle, who have probably been committed a number of offences and have a history of failing to turn up to court. Then I think that is custody the right way forwards in those terms? Are there not other ways of ensuring that the court's orders are adhered to? So I have a concern about that issue. And then, of course, I have a concern about how they're being treated in prison, because particularly where a prison may be overcrowded, in inverted commas, there is not as much interest or direct intervention going on with prisoners on remand as there are for other prisoners. And I find that perplexing. So that really prisoners on remand have, I think I say in the report, yes, access to physical exercise in the gymnasium, and yes, good access potentially to their families. And they have, I think, a privileged access to families compared to other prisoners. But is this not an opportunity to do and intervene in other ways in terms of how we should be taking this forward, particularly if they're younger people? Because if we're in the last chance saloon for young people, you have an opportunity, whether they're guilty or they're not guilty, to do something about it. And then, of course, there's that last piece of, have they lost their house? Have they lost their job? Have they lost their family? And therefore, is there not another way you can do remand that means that you don't have to lose those three things? Perhaps that, and I don't know how you would do this, perhaps you would think about putting them in prison overnight or whatever, and allow them to carry on with their job or to go to school if they're of that age. I mean, I think there are ways where you've got to look at this in a different way. Just putting people in prison because it seems to the court in a particular way. And I'm not trying to criticise courts, so I'm not suggesting this is easy, but I just think we need to look at this in a practical way and try and come up with better solutions.
Yeah. And are you optimistic that dialogue is going to happen now, or Are you uncomfortable about it still?
I don't inspect optimism.
It's another person not going to smile along with Graham. Can I just come in with a supplementary? I was going to ask you about remand because I go back to days chairing justice when Clive Fairweather was Inspector of Prisons, and you know we were at his service together. And he said exactly the same as you're saying now, which is a bit depressing 13 years later, about the worst conditions of the prisoners on remand. There's 2 men remand. 50% are not convicted at the end of the day, so they've been in prison for a period of time, and yet they're innocent. Is there not a route, I'm not sure about this, but tagging isn't used for people on remand, is it? If they're not a danger to the public, could we not use tagging and keep them in their jobs, keep them within their family while we go through the court process?
I think, and I think what I'm saying is we need to look at this in a much wider way. What are the opportunities here for doing this? And I think separate those people who the court would feel were a security issue, a safety issue, and those who are just troublesome in another way. And I'm sure there are ways of doing this. And I think we have much more intelligent tagging systems now that I think would fit this bill very well.
Have you raised this? Has it been raised anywhere and just disappeared?
Not that specific question, Convener, but I have certainly suggested it. But of course, I can only report on these issues. I can only tell you what I see. I can only publish a report, and I think I was asking, was it a response to this? Has there been a response from either the SPS or the Cabinet Secretary or anyone with regard to alternatives to placing people in prison on remand if they're not, while still innocent till proven guilty? There's an issue perhaps about danger to public or something in certain circumstances, but in other circumstances there isn't. Therefore, as long as you can track where they are in their home or whatever, they can keep their work, keep their jobs, especially as we now know 50% are not convicted at the end of it. So you've banged up people who were innocent. I certainly had acknowledgement from both the Cabinet Secretary and officials. I know there is good work going on in government to try and look at this, but I haven't seen specific ways forward put down and are going to be implemented. So I think all I can really do is raise the issues. I think one that really needs to be tackled.
You could raise it as well. Rod, you want to come in and remand as well?
Actual kind of information in terms of records you were made available to you to dealing with different categories of people on remand, for example, who might have been remanded because of threat or potential intimidation of other witnesses or possibility of further offences. Did you have actually kind of detailed information on different categories of remand prisoner or not?
No, I haven't. We looked at this as a general category. The information I got in terms of the 50% was pretty approximate. I don't have a PhD in statistics, so I had to be fairly careful how I did this. But there is, I know, work where they are trying to look at in Scottish Government where what's happening to these people. But rather like reoffending rates, it's not an easy category to measure. So that's why I've been fairly approximate in my statistics on that issue. But I do not, to answer your specific question, I haven't seen how many were on what you might call in a particular security category.
That is something that we could take up with the Scottish Government ourselves. Thanks.
Yes, thanks, Rod. Sandra.
Thank you very much, Chair. Possibly most of my questions have been answered because I was going to ask about the overcrowding and the remand situation. I would just like to ask you, why are so many prisoners on remand? I know some are in and out on bail, back in again. Why are so many prisoners on remand? Do you have an answer to that one?
I don't think I have. I think there are.
Forgive me a minute. I think it's a matter for the sheriffs and the judiciary to make these decisions.
I was going to come on to that one, but I just thought I'd ask.
So really, it isn't really a matter for the Chief Inspector of Prisons to know why a sheriff decides somebody should be put in remand.
Can I ask then, the Chief Inspector of Prisons, have you ever raised this with sheriffs or anyone else or prisoners, etc.?
Informally, I have. Informally. In discussions with sheriffs, one will ask these sort of questions, and in a way, I don't really want to put sheriffs in an awkward position.
I think we should pursue this. I think it would be unfair if you've had informal discussions with the bench.
Could I ask another question? I think possibly it's because they're not giving custodial sentences at basis. So that brings us back to that, but I'll leave that to an aside. You mentioned about activities, and one of the comments was that the reason that remand prisoners, can't get involved in activities whilst they're, obviously there in custody, is hampered by the need to separate them from convicted prisoners, and also by overcrowding, which is another issue I was going to ask, and no legal requirement for them to work. How would we get round that? I know the convener's mentioned about perhaps you could tag and they didn't need to be there. But it would be helpful, though, for them to be able to be involved in activities. And how do we get round the difficulties of them not being able to be involved in activities?
Well, I think this comes back to points I've made in terms of mentoring and leadership. There is a bit about the prison regime and having to keep those on remand separate from those under sentence. And in many respects, I think that is entirely right. But I do think that, and there are a number of those on remand who don't want to engage in, and because they're not under sentence, there is very little effort to try and make them or not try and encourage them. I would like to see more encouragement. I think there is more outreach, perhaps, not so much for them to go into the education centre, but perhaps for education to be offered to them, for encouragement to be offered to them. I think also you could do a lot. I was very interested to hear about the discussion you were having earlier about addictions. Some of these people may well have an addiction. So whilst the clinical medical piece will be dealing with that, and they may well be on methadone or whatever. I think this is where you could be doing some engagement on alcohol and drugs, if only to offer it as a service that you would hope to get outside. Why can't you have it inside prison? I don't think there needs to be any stigma attached to that. I think we have to look at these people as an opportunity, not a threat. For goodness sake, these people haven't yet been found guilty. They may not be guilty, but it doesn't matter. They're in there because because the police or the court have decided they should be. So there may well be an underlying issue that you can deal with, and I think that we ought to make an effort to treat them as individuals, to induct them into the prison in a way that tries to understand them better and tries to at least begin to get them on the right course, if only to get them connected when they go back out again. I don't see enough of this going on.
Thank you very much, Convener. That's a very interesting point. Thank you.
I've got Jenny, followed by Colin, followed by Graham.
Thank you, Convener. I have two separate points, if that's okay. And the first one follows on from Sandra's question. Brigadier, earlier this year I visited Castle Huntly Prison, Perth Prison, Polmont and Cortonvale. And after those 4 visits, I was particularly struck by the lack of purposeful activity, as you put it in your report, and rehabilitation programmes properly structured and thought out. I wonder if you can expand. I know you've made some points on this on the remand programme, but I wonder if you could give us your thoughts on how satisfied you are with the rehabilitative process in our prisons generally.
I think strategically not very satisfied at all in terms of delivery. When you're I'd say that in terms of what's the point of prison. Clearly there's a safety security piece, there's a punishment piece, which I think is one element of prison. But it strikes me that if we are going to reduce reoffending, if we are going to give people another chance, they have to have the very best possible access to purposeful activity that suits them as an individual, to give them the best possible chance when they get back out, and to give that community the best possible chance of connecting with them to take them forwards. And I don't think there's enough done about that. We sometimes use the word rehabilitation, I think, wrongly. It assumes that at one stage these people, these offenders, and I don't mean to stigmatise them generally, have the proper foundations of living a successful life already in place. For many of them, they haven't got that in place. Many of them have found education as a challenge. Many of them got a drug and or an alcohol problem. They've maybe come from a pretty chaotic lifestyle and upbringing. So they've never even had the foundations put in place. And I think sometimes I think rehabilitation suggests we go back to where they were before. No, we need to start again in almost respects and rebuild foundations so that when they go out, they've got a much better chance of surviving. So my point, which I think you have thrown back to me, is absolutely that rehabilitation and the building of these foundations should be absolutely central to the way that prisons function, that we should get the maximum number possible to work or vocational training or education. It's interesting, isn't it, that when you look at the prisoner wages structure, if prisoners go to education, their wage drops. I find that rather bizarre. Sorry?
From what you've seen in our prisons, sir, do you think that what is the best way to put these programmes together? Would it be a national strategy, or do you think it's up to individual leaderships from the governors in prison, or do you think it's incumbent on the people, the colleges who are tasked to deliver these programmes? How far up the food chain do you think that kind of strategy should go?
Well, I certainly think there ought to be a national view about rehabilitation. In other words, what's the point of this and what are we trying to deliver? And maybe we can then measure it in a sensible way when people get back out into the community. There is an issue about the contract for the education providers, the two colleges, Motherwell and Carnegie colleges, because the contract that was only signed, just over a year ago, is very much based on literacy and numeracy. But that's not always what the problem is. And so it's become a very narrow approach to this. And I think we should have taken a wider approach to education and learning and what's most appropriate for the individual. When I inspected Castle Huntly this year, and I think it's in the report, I specifically commented that there's the education centre at the open prison at the end of their prison process, still talking about literacy and numeracy, when surely we're talking about how are we going to deliver these people on that final stage into the community. If they haven't learned to read and write by the time they get to Castle Huntly, there's not much hope for them. So we need to apply education and learning most appropriately for the people we're talking about, whether they be young offenders or people who are getting out into the community. So I think we need to, yes, I think there needs to be, whether it's strategy is the right word, there needs to be certainly delivery in terms of what we're trying to do and measurement, a through care measurement process. Because again, like many of the other things we've been talking about, no one can tell me how well we're doing on this. But I do think the figures that I think I've quoted, not in my last report, but the report before, were really very low. I mean, I think at that stage, Cornton Vale was at 35% out at activities. Glen Oakle, I think, was at 50%. We should be having, if rehabilitation is so important, then surely the figures should be up into the 80s and 90%, and that everyone should be encouraged, either within their hall to participate in an activity or elsewhere in the prison. And if it's not up into the 80s and 90s, then I think we're failing. Can I just make one other point, which I think is a point about technology? When I've inspected Addywell Prison, it has technology where prisoners go to and you will have seen them, those holes in the wall where they dial up their menus and the menus for their food, arrange their visits and so on. But apart from that, it's also included booking their activity for the week ahead. And that has a database behind it. And because there's a database, when I said to Addywell, your access to activity is only at 65%, this is not good enough, they were able to increase it by 15% when I did a follow-up inspection, because they were able to interrogate the database and do their timetabling better. In other words, to get the right people to the right place at the right time. And yet, it's ironic that only the private prisons have got technology with a database to manage prisoners. None of the new prisons have got this new technology. So they're not able to interrogate the database and get the right people to the right place at the right time. This is a very local issue, but in my view, in terms of spending money, surely it's exactly the right sort of spend we should be encouraging.
Can I ask my second?
Yes.
My second question, Brigadier, is can you please give us your thoughts on the government's proposal to change the prison visiting arrangements?
Oh, in terms of the visiting committees?
Yeah.
I'm not sure I should. Well, I can give a very short answer.
Teasing, say, I'm not sure I should, and then you're going to say something.
Well, the reason I say it is because Professor Andrew Coyle is looking at the arrangements, and that arrangement is that I should take over the monitoring of prisons, having within the inspectorate and under my charge a prison monitoring service. Those arrangements have been made public, I think. I have said that I would be content to take that on under certain provisions, but I think while Professor Coyle is doing his review for the Cabinet Secretary, I think it would probably be wrong for me to go into any more detail, if that's all right.
Thank you.
That's very diplomatic. And also, I think the committee will take evidence in any event. I believe it's an affirmative instrument when we will take evidence in prison visiting committees. Colin, followed by Graham.
Good afternoon. It's actually something you alluded to when you were speaking with Alison, and it's really relating to family access, where in your report, obviously, you give places of good practice and not so good practice. My question really is, what is your view of the way that those who you have been critical of are taking on the issue of family visits and general interaction, given that they have been criticised and obviously the problems that they're encountering at this moment in time? How do you think the forward planning is going?
Well, I think if I started, thank you for that, because I think this is a really important part of prison. And I'm absolutely clear in my own mind that Scotland should be at the leading edge of this. We really need to understand, in my view, that this isn't about arranging visits to prisons. This is about making a genuine attempt to rehabilitate prisoners back into the community better, using families as the solution, not the problem, and a genuine attempt to get everyone to understand how we're going to do that, and a genuine attempt also to engage with the families of prisoners to help them, and they themselves may have issues of health or education or other wider aspects that visiting prisons can help with. So I think it's absolutely central to what prisons are trying to do. And so I was in the past very unhappy, first of all, by the real resistance against my proposal that every prison have a prisoner visitor centre, such as they have at Edinburgh and Perth, because that's where you can support and help prisoner families so much better. And also a resistance in many respects in terms of really trying, particularly this was relevant to Cornton Vale, really trying to make visiting facilities of a sufficient standard. And indeed, in some prisons, Aberdeen was a case until they produced a porter cabin, which is much better, and Cornton Vale was a particular case where, frankly, the visit room arrangements were shocking. Now, I think what has happened since April this year with the new chief executive coming along is a complete change. The resistance that I felt in the past has gone, and we're now pushing on an open door. I was particularly pleased to hear, and I spoke to Kate Donegan last night at the Prisoner Week service at Dunblane Cathedral, a great event last night, and the new visitor centre at Cornton Vale, I think, will be up and running quite soon. I'm not quite sure what quite soon is, but much better than it was going to be. So I think that will make a huge difference. And just the fact that the chief executive immediately accepted not only my recommendation, but particularly Dame Eilish Angelini's recommendation on that, was such a change in the way that the prison service have viewed this that I think I am now optimistic, and I'm almost tempted to inspect this optimism. So I think that, to answer your question, we now need to look at how do you take this forwards. Firstly, I think we've got to make sure that there really is provision in new prisons for there to be a proper up-and-running visitor centre, and I'm glad to hear that now at Grampian there is going to be one, and I'm sure in any future prison there will be one, and that will be a huge step forwards. How you then backfill, if, as it were, older prisons will be difficult, but I think has to be done. I've been to visit in England visitor centres. I think I'm right in saying every prison in England does have a visitor centre, but principally actually to process visitors rather than anything else. But there they can use a porter cabin. I mean, we don't have to have an architectural gem like we've got at Edinburgh Prison to make a visitor centre. It can be a porter cabin. We need to backfill all those old prisons that don't have one. But I also think, in the last part of this, is I think we need to look at what are these visitor centres doing. I think they need to do more than just providing a cup of coffee and an arm round the shoulder. I think this is where actually health and education can become part of the connections you can put into families. These are families coming from, in many cases, the most difficult and challenging parts of Scotland. So why don't we use these as ways of trying to support and help the families better? So I think we need to take visitor centres on, call them help centres or something, but take them a stage further forwards and see if they can't do even better and produce a better result. As one example, I would say I often come across, I do a lot of dealings with Dyslexia Scotland. I come across a lot of prisoners who have dyslexia, often not assessed properly, and I have to take their word for it. But I'm told that dyslexia is often passed on from generation to generation. So why isn't there, for example, at each visitor centre some information for families about dyslexia? Because the children may well have dyslexia. Have they been tested, and what are their? So I think there are lots of things we can do with these, and we need to have much more ambition in the way that we deliver families into prisons and make this more acceptable for the future. I'm not sure if that's answered your question.
Sounds good enough for me.
Yeah. You also mentioned the family contact officer should be given a higher priority. Is there only one family contact officer in a prison, or are there several? And how are they not given a higher priority? Are they way low down the pecking list?
It depends. Most prisoners, I would hope, would have at least 2 or 3. Is that enough? It depends. How long's the piece of string, really? For example, at Polmont, where obviously you've got quite a parental interest in what's going on, I think I would like perhaps to see more. And how do you keep that sort of family contact going with young people, particularly under 18s? And they have just at Polmont, I think, increased the number of contact officers. I remember inspecting Glen Oakle and saying that they need to have more family contact officers. They did put more family contact officers, and then, because they had a staff shortage, they had to take them away again. So therefore, we take away from that, are family contact officers the highest priority in the prison? And I think the answer is probably no. Should they be? Yes. Given the answer I've just given, I'm absolutely convinced that this is the way forwards. If we are really going to connect families and prisoners and families and communities, then we have to take a real change in the way we take this forwards. Because it's not just about the prisoner, it's also about the community and the prisoner family within the community. I heard last night at the service in Dunblane that in Singapore, apparently when prisoners are released from prison in Singapore, the community celebrates, and they tie yellow ribbons around the old oak tree and so on. We don't celebrate this at all. the community is not ready for this to happen. We're almost of the opposite view. And I wonder if we invested more in our families, therefore we would be investing more in how communities deal with this whole situation in a more positive fashion.
Thank you. It's an interesting response. Graham.
Thanks,
This will be the last one.
In the context of all the things that you've just said just now, and it may well be that you have no advice to offer us, but I'll ask the question anyway. A high proportion of people in our prisons come from a background of having been in care and been looked after. Given the privileged access that you've had to prisons over these years and the knowledge that you've accrued, have you any advice to the committee about that linkage between children in care who eventually come into the criminal justice system and prisons? Are there things that occur to you that we should bear in mind for the future in dealing with that potential link? Because it seems a very high proportion of young people end up in Pullman who have come from that background.
No, and I think that that's absolutely right. And when I've been to the secure units, I've been to visited 3 secure units. I sometimes wonder, and I don't inspect secure units, as you know. I sometimes wonder whether we're getting a real return on the considerable amount of money invested in that, and whether we don't need a greater involvement by the third sector here in terms of trying to treat these people as individuals, but within the community. I go and visit a number of third sector organisations who do precisely that, mentoring within the community and trying to help each individual person make progress. I'm not sure that's answered your question about care, except that I do think this does require each individual child needs that care. And I'm also not clear. I haven't seen the figures. When I went to the secure units, could they tell me how many were going to go on to Pullman? And it was, I think at that stage, that was probably about 2 years ago. It was indistinct what the precise figures were, but my impression was that somewhere over 65% were going to go off to Pullman. That seems to me to be a very high number, given the investment and the process that goes on a secure unit. That I don't think is intended to be a criticism of secure units. I think it's a criticism of our lack of understanding of the data. And why is that? Is that because they've been given such a long sentence that they're going to go there anyhow, in which case that's understandable? Or is that because they will re-offend on going back into the community, in which case we need to understand that figure a bit better?
And I understand the response that you've given me there and the perspective you've taken. My experience has indicated, and it came as a shock to me when I discovered that the majority of children who are in our residential care out with these detention units are there not for criminality. It's because of the breakdown in family circumstances and other issues. And the thing that worries me is that having come into our care, a substantial number of them end up in the criminal justice system. And I just wondered if you'd gleaned anything in your journeys around prisons that would give us some hint as to what we might do about that part of the linkage. Once they're in these detention centres, you know, the deal's broke almost, but it's this earlier stage.
I think if the care is you're grouped together with fellow people in care, I have a slight comparison with it. If we're so worried about young people going to Pullman and what they will learn in Pullman from each other, then don't we take the same in terms of care? How do you, because inevitably, and I think this is what goes on in secure units, you may go to a secure unit and I guess to care with a behavioural problem or some other underlying issue, but it may not be a criminal one. But you may well meet people who are of a different criminal background, who are, in inverted commas, bad. In which case, is it wise to put people in that situation? And that's where I think perhaps a third sector approach, where you're perhaps looking more at, I think my example is Includem, which uses a sort of an individual in the community approach rather than a putting people into care together approach. I think I'm probably on the edge of my knowledge here, but I think it may well be of...
It's another huge issue. If you're on the Justice Committee, you make these huge complex issues, as you do all the time. I think that's almost a separate investigation, you know, for us. Well, now, what I wanted just in conclusion is, without the members asking any questions, now, if you have any comments you wish to make, or may wish to make later with regard to the previous evidence session, from your experience of inspecting prisons, of the transition and now the delivery of the health care within prisons by the NHS rather than the SPS.
And I think, thank you for that, Convener. And I think I just wanted to say that I thought it was a very interesting session. I thought Frank Gibbons' comment about this being early days was quite intriguing. He used to be one of my healthcare inspectors before this came on. I now use an inspector from Health Improvement Scotland. And he used to be one of my healthcare inspectors. So I know Frank Gibbons very well. And he has a very deep knowledge and understanding of prison healthcare. So I thought his view that this is still early days was relevant, and certainly relevant to me. I've only inspected 4 prisons since... the NHS have taken over. And having looked at it, I can't give much more than a generalisation of where we are. I think it is certainly true to say that the process of transfer went well, but that each individual prison and the board it was dealing with perhaps did that in a different way. And of course, it's compounded, the complications compounded by the fact that some prisons are national prisons and some are local and some are both. So but I think we've got through the process of transfer perfectly well. And I think the important thing to take away also was there is now an opportunity for improvement. Now that it's been done, there is, I think, a very good opportunity for improvement. The important point being, I think, through care can improve so much more and is already beginning to do so. I still have 2 major areas where I'm still quite concerned, and I have raised these concerns before. One is on addictions, where I have said that a number of things. I said it actually in my previous year's annual report, where I think, I think there isn't enough done to encourage and support prisoners to get off methadone or reduce their methadone. And I see methadone as a perfectly sensible clinical process, mechanism. But I see so often prisoners use methadone either to maintain their dose or indeed in some cases increase it. And I'd like to see more thought put into how we actually deliver that part, whether there is enough individual... I'm sure that I'm not trying to make a clinical point, it's not my business, but whether there is enough mentoring and leadership and persuasion about how we're trying to deal with this very complex underlying issue. Whether there is enough done about alcoholism in prisons, and I don't see enough access to programs about alcohol going on. Much more of an effort on drugs, not nearly enough on alcohol. And on mental health, I think we've talked a lot about mental health this morning. I think I have a particular concern about mental health and about mental health training, not just for the experts but for the whole prison, and trying to deal with that. And the last point on addiction. I apologise for coming back to this. Was I don't see enough measurement of trends, and I've said this in reports. On what drugs are we talking about? Are these is use of heroin going up or down in prison? I mean, we've got this population. Why aren't we measuring the trends of coming in? How are they? Is the trend going up or down in terms of testing positive on coming into prison? What are the drugs of use, and how are we dealing with them? So I think the measurement is poorly done, and I don't see enough a proper comprehensive testing regime on drugs, which would give us a much better clue about the smuggling of drugs into prison. Is it still an issue? And if so, what are we doing about it? So I think this is that's a testing and measurement issue, really. But I thought otherwise it was a very interesting, discussion. But I was interested that there's still quite a lot of work still to do.
You heard us saying probably we'll return with the same questions in 6 months to see if we're getting same or similar answers and if there's been progress. Well, can I thank you very much it's been a long morning waiting there, and thank you very much for your attendance. I'm going to move on, given the pressure of time, everyone, to item 3 very quickly. Subordinate legislation. It's a negative statutory instrument of the Criminal Legal Aid Scotland Fees Amendment Regulations 2012 SSI 2012-276, making new provisions relating to fees payable to senior and junior counsel for criminal legal aid work, conditions of payment. Members will see from the clerk's paper that the sub-ledge committee has identified that in the table of fees listed in the regulations, a reference to the Road Traffic Act 1998 should have been the Road Traffic Act 1988. No doubt somebody's had their fingers wrapped for that. Members should be aware that the Scottish Government has accepted that this is an error and has already lodged a second negative instrument to correct the mistake. I suppose it deletes one digit and puts in another one. The committee will consider the amending instrument in due course. Do you have any comments? Because we're going to consider it, the amending one as well. No comments? Oops.
Can I just refer to my declaration of interest?
Yes, certainly, as a member of the faculty, Rod.
Yep.
Right, you're content to make no recommendations in relation to the instrument? Thank you very much. The next meeting is on Tuesday, 27th November, when we'll take evidence from Her Majesty's...
Before we finish?
Oh, yes?
Can we get some indication? We had a panel booked for next week. Have we got confirmation that they're all attending?
I'm about to do this.
Oh, that's fine. Just I thought we were closing up there.
The committee's next meeting is Tuesday 27th, when we'll take evidence, if you just bear with me and make you smile, from Her Majesty's Inspector of Constabulary of Scotland, the Chair of the SPA and Chief Constable House on issues around police reform. Was that your question? Excellent. It is now answered. That concludes the meeting, and I close it formally.
Thank you, Convener.